Blood sprayed across the sterile walls of Thornfield Military Hospital in Detroit as trauma surgeons screamed over a dying three-star general's convulsing body. The nation's most decorated combat commander was bleeding out on American soil, and the country's elite medical team was losing him. Monitors shrieked, hands shook, voices cracked with panic. Standing silent beside the instrument tray was Sarah Brennan, a pale, sharp-eyed military nurse with 4 years of battlefield medicine experience that nobody in this operating room gave a damn about. They'd spent 6 months treating her like furniture, mocking her field training, dismissing her observations. Now the general had 90 seconds left to live, and every brilliant surgeon in the room was about to let him die. Because none of them would listen to the one person who actually knew what was killing him. If you want to see how this story ends, stay with me until the very last word. And please, like this video and comment your city below so I can see just how far this story has traveled across the world. The emergency bay doors exploded inward at 0247 hours on a frozen February night, and Sarah Brennan knew immediately that someone important was dying. She'd been restocking trauma bay supplies when the alert blasted through the hospital intercom. All personnel to emergency surgical, full lockdown protocol, media blackout in effect. Within seconds, armed military police flooded the corridors. Phones were confiscated. Exterior doors sealed. Sarah had seen this exact response pattern twice before during her deployment in Syria, both times when high-ranking officers came in shredded by IEDs. The medics wheeled the gurney past her at a full sprint. The patient's uniform was so soaked with blood that Sarah couldn't see the rank insignia, but the 8-man security detail trailing behind told her everything she needed to know. "Thornfield, we have incoming 3-star General Marcus Holloway," the lead paramedic shouted into his radio. "Multiple penetrating shrapnel wounds, suspected internal hemorrhaging, blood pressure dropping." Sarah's hands went cold. General Holloway, the man who'd commanded the entire Eastern Theater. The strategist who'd planned the operations that Sarah herself had supported in Aleppo and Raqqa, treating his soldiers when they came back torn apart. Now he was the one bleeding out. She followed the chaos into Operating Room 3, where Chief Surgeon Dr. Preston Caldwell was already barking orders at his team. Caldwell was a tall, silver-haired cardiovascular specialist who'd trained at Johns Hopkins and never let anyone forget it. He ran Thornfield's trauma unit like a corporate boardroom, hierarchical, pristine, and utterly intolerant of anyone who hadn't graduated from an Ivy League medical school, which meant he'd hated Sarah from the moment she'd transferred in from field service. "Brennan," he snapped without looking at her. "Instruments, and stay out of the way." Sarah moved to the prep station, her jaw tight. 6 months at Thornfield, and that was still the longest sentence Caldwell had ever spoken directly to her. The surgical team swarmed the general's body like wolves on a carcass, cutting away the destroyed uniform, inserting lines, clamping bleeders. Sarah watched the monitors while her hands automatically arranged scalpels and retractors. Heart rate 142. Blood pressure 78/45 and falling. Oxygen saturation 89%. He was crashing, and they hadn't even opened him up yet. "Get me 4 units of O-negative, Caldwell commanded. "Start massive transfusion protocol. I want a vascular surgeon in here now." Sarah's eyes tracked across the general's exposed chest. The shrapnel wounds were concentrated on the left side, at least 7 punctures ranging from his clavicle down to his lower ribs. Standard fragmentation pattern from an anti-personnel device. She'd seen this exact injury profile 24 times in Damascus, but something was off. The general's breathing had a faint whistling quality that didn't match the wound locations. It was subtle, almost buried under the ventilator's mechanical rhythm, but Sarah had learned to hear those tiny discrepancies in field hospitals, where monitoring equipment didn't exist and your ears were the only diagnostic tool you had. She leaned slightly closer, listening. There, a high-pitched wheeze on every exhale coming from somewhere near the trachea. "Dr. Caldwell," she said quietly, "I think there might be an airway. I think you might want to focus on your actual job." Caldwell cut her off without even glancing up. "Which is handing me instruments when I ask for them." 2 of the younger nurses exchanged uncomfortable looks, but nobody said anything. They never did. Sarah stepped back, her face burning. Dr. Julian Voss, the senior trauma surgeon assisting Caldwell, was already wrist-deep in the general's chest cavity, his hands moving with the kind of confident speed that came from 1,000 successful surgeries. I've got active bleeding from the subclavian artery, he announced. Clamp! Sarah handed him the vascular clamp automatically, her mind still processing that wheeze. It didn't fit. Subclavian damage wouldn't cause that sound. Suction, Caldwell ordered. Sarah passed him the suction tube, her eyes never leaving the general's throat. The surgical team worked with mechanical precision for the next 40 minutes, clamping vessels and extracting shrapnel fragments. Blood loss was severe, but manageable. The transfusion protocol was keeping the general's pressure stable enough for the surgeons to work. Everything looked textbook perfect, except that wheeze was getting louder. Sarah's instincts were screaming now, the same visceral warning system that had kept her alive through mortar attacks and mass casualty events. In the field, when something felt wrong, you didn't wait for confirmation. You acted. Because hesitation killed people. But this wasn't a field hospital. This was Thornfield Military Medical Center, where protocols mattered more than instincts, and nurses who spoke out of turn got reassigned to inventory duty. Still, she couldn't let it go. Dr. Caldwell, she tried again, keeping her voice level. The airway sounds compromised. I'm hearing... What you're hearing, Caldwell interrupted icily, still focused on the surgical field, is the sound of a ventilator doing its job. What I'm hearing is a nurse with 6 months of hospital experience trying to diagnose a patient during a critical operation. Do you see the problem here? Sarah's hands clenched around the instrument tray. Dr. Voss didn't even look up. We've got the airway secured, Brennan. ET tube placement was confirmed before he even left the ambulance. I understand that, Sarah said carefully, but I think the tube might have shifted during... You think? Caldwell's voice could have cut steel. You think? We don't operate on what nurses think, Ms. Brennan. We operate on evidence, training, and 15 years of cardiovascular surgery experience, which you don't have. The entire operating room went silent, except for the rhythmic beeping of monitors and the hiss of the ventilator. Sarah felt every eye on her. The other nurses looked mortified. The junior surgical resident looked like he wanted to disappear. Even the anesthesiologist was staring at her with a mixture of pity and secondhand embarrassment. She should stop. She should shut up and do her job and let the brilliant surgeons handle the medicine. But that wheeze was still there, and it was getting worse. With respect, sir, Sarah said quietly, I spent 4 years treating blast trauma in Syria. I've heard this exact sound before, and it means... What it means, Caldwell said, finally looking directly at her, is that you're still thinking like a field medic instead of a professional nurse. There's a reason we have hierarchies in modern medicine, Ms. Brennan. There's a reason we don't let combat medics with correspondence degrees make diagnostic calls in state-of-the-art trauma centers. Do you understand what I'm saying? The condescension in his voice was so thick Sarah could taste it. She understood perfectly. She'd heard variations of this speech from Caldwell and his colleagues for 6 months straight. Combat nurses were battlefield amateurs. Real medicine happened in hospitals, not tents. Her 4 years keeping soldiers alive under fire meant nothing compared to their prestigious residencies and published research papers. Sarah's jaw tightened, but she nodded once. Yes, sir. Good, Caldwell said. Then let's focus on the actual emergency, shall we? He turned back to the general's chest, and Sarah forced herself to stay quiet. But she didn't stop listening, and that wheeze didn't stop getting louder. The surgery continued for another 2 hours. Caldwell and Voss worked methodically through the damage, repairing the subclavian artery, removing 17 pieces of shrapnel, patching a punctured lung, cauterizing dozens of smaller bleeders. It was technically flawless work, the kind of performance that would get written up in medical journals. Sarah handed them instruments in silence, her eyes constantly flicking between the monitors and the general's throat, heart rate climbing. 156 now, oxygen saturation dropping, 84% E, 81 or 78. The anesthesiologist frowned at his screens. Sats are falling, he reported, increasing oxygen flow. Probably just atelectasis from the lung trauma, Dr. Voss said dismissively. It'll stabilize once we close. But it didn't stabilize. 74%, 70%, and 68. He's desaturating, the anesthesiologist said, concern creeping into his voice now. I'm not getting good air movement on the left side. Caldwell barely glanced up. We already reinflated the lung. Check your tube placement. The anesthesiologist double-checked the endotracheal tube. Placement is good. 22 centimeters at the teeth. Bilateral breath sounds confirmed. Except Sarah could hear that they weren't bilateral. The right side sounded normal. The left side had that thin, reedy whistle that meant air was leaking somewhere it shouldn't be. "Dr. Caldwell," she said quietly, I really think you should stop talking," Caldwell snapped. "Unless you're handing me a suture, I don't want to hear your voice." Sarah bit down hard on her response and stayed silent, but the general's oxygen saturation kept dropping. 64%. 60%. "I'm losing him," the anesthesiologist said, real fear in his voice now. "Pressure's crashing too. 80 over 50, 70 over 40. Caldwell's hands paused for the first time all night. "That doesn't make sense. We've controlled all the major bleeding." "Well, something's wrong," the anesthesiologist said, "because he's dying right in front of us." The operating room erupted into controlled chaos. Nurses rushed to hang more blood products. The surgical resident started chest compressions. Dr. Voss frantically rechecked every repair they'd made, searching for a missed bleeder. Sarah stood frozen at the instrument table, her mind racing through everything she'd learned in Aleppo and Raqqa and Damascus. She'd seen soldiers die from internal bleeding. She'd seen them die from shock. She'd seen them die from infections and from combat wounds that were simply too catastrophic to survive. But she'd also seen them die from blocked airways that nobody noticed until it was too late. The general's chest was barely moving now despite the ventilator's mechanical pumping. His skin had gone gray. The monitors were screaming. "I'm not getting a pulse," the resident said, his voice cracking. "Starting epi." They pushed epinephrine. They pushed atropine. They pushed everything in the crash cart while Caldwell and Voss tore through the chest cavity, looking for a source of bleeding that didn't exist. And all Sarah could hear was that goddamn wheeze, quieter now because there was barely any air moving at all. She knew what was happening. She knew exactly what was killing General Holloway, but nobody would listen to her. At 0512 hours, after 4 brutal hours of surgery, the monitor flatlined. The continuous tone cut through the operating room like a scream. Everyone stopped moving. Dr. Voss had blood up to his elbows. The surgical resident had tears in his eyes. One of the younger nurses turned away, her shoulders shaking. Caldwell stood completely still, staring down at the general's gray, lifeless face. "Time of death," he said quietly. 0512. The words hung in the air like a death sentence for everyone in the room. Outside in the corridor, Sarah could hear the waiting soldiers. Someone was crying. Someone else was shouting demands for information. Military police were trying to maintain order, but grief was spreading through the building like a firestorm. The nation's most decorated combat general had just died on American soil, and Sarah Brennan was the only person in this operating room who knew why. Her hands were shaking as she stared at the general's throat, at the endotracheal tube that everyone had checked and double-checked and confirmed was in perfect position. Except it wasn't. She could see it now, the slight displacement, the subtle angle that meant the tube had shifted during transport or during the initial resuscitation. Not completely out of place, just enough. Just far enough that the tip was resting against damaged tracheal tissue instead of maintaining an open airway. The surgeons had been so focused on the shrapnel wounds and the bleeding that they'd never considered the simplest explanation. The general hadn't died from blood loss. He'd suffocated slowly over 4 hours while the best trauma team in the military fought to save him from the wrong problem. Sarah looked at Caldwell, at Voss, at all the brilliant, experienced, award-winning surgeons who just let a man die because they were too arrogant to listen to a combat nurse. Something cold and hard settled in her chest. She stepped forward. "No," she said. Every head turned toward her. Caldwell stared at her like she'd lost her mind. "Excuse me?" Sarah's voice was steady, calm, the same tone she'd used in Syrian field hospitals when she had to cut into dying soldiers without anesthesia or backup. "He's not dead yet." "Nurse Brennan," Caldwell said slowly, dangerously, "step back from the table." Sarah didn't move. She was staring at the general's throat, at the faint, almost imperceptible tremor in the tissue around the endotracheal tube, a micro-movement that nobody else could see because they weren't looking, because they'd already decided he was gone. But Sarah had learned in the field that bodies fought to survive long after monitors flatlined, that sometimes there were 30 seconds, 60 seconds, maybe 90 seconds between clinical death an actual death. A window where a human being was still alive even when all the machines said they weren't, and her combat instincts were screaming that General Marcus Holloway was still in that window. "The airway is blocked," Sarah said clearly. "The tube is displaced into damaged tissue. He can't breathe." Caldwell's face went dark red. "We have checked that tube 4 times. "You checked the placement depth," Sarah interrupted. "I'm telling you to check the position. He's not bleeding out anymore. He's suffocating." Dr. Voss looked at her like she'd grown a second head. "The tube is exactly where it's supposed to be." "No," Sarah said flatly. "It's where you think it's supposed to be. But I've been listening to his breathing for 4 hours, and I'm telling you that tube shifted during the initial trauma response, and you've been ventilating dead tissue while he slowly died from hypoxia." The silence in the operating room was absolute. One of the nurses gasped softly. The surgical resident's eyes went wide. The anesthesiologist looked between Sarah and his monitors with growing horror. Caldwell stepped toward her, his voice shaking with rage. "You have lost your mind," he said. "You are a nurse. You do not make diagnostic calls during a code. You do not override attending physicians. And you sure as hell don't accuse this surgical team of negligence while a general officer lies dead on this table." "He's not dead," Sarah said again. And then she moved. She didn't wait for permission. Sarah's hands moved with the kind of muscle memory that came from treating soldiers in buildings that were actively being shelled. She grabbed a laryngoscope from the instrument tray and stepped directly into Caldwell's space, forcing him backward. "Get away from my patient," Caldwell snarled, but Sarah was already leaning over the general's body. She pulled the laryngoscope into position and looked down the general's throat. The endotracheal tube was there, exactly 22 centimeters deep like the anesthesiologist had confirmed. But the angle was wrong. The tip wasn't centered in the trachea. It was pressed against the posterior wall, embedded in tissue that had been shredded by shrapnel and was now swollen shut around the tube. Every breath the ventilator had pushed for the last 4 hours had gone straight into damaged tissue instead of the general's lungs. "Jesus Christ," Sarah whispered. She didn't have time to explain. She didn't have time to convince anyone. The general had maybe 60 seconds left before his brain cells started dying from oxygen deprivation, and Sarah had already wasted 10 of them arguing. Her hands went to the tube. "What the hell are you doing?" Dr. Voss lunged toward her, but the surgical resident grabbed his arm. "Let her work," the kid said, his voice shaking. Sarah pulled the endotracheal tube back 3 centimeters, angling it away from the damaged tissue. The resistance was immediate. The tube had been partially embedded in the swollen tracheal wall, and extracting it felt like pulling a blade out of meat. The general's body jerked. Not a muscle spasm, not a post-mortem reflex. A response. "Bag him," Sarah snapped at the anesthesiologist. "Now!" The anesthesiologist stared at her for half a second, then grabbed the ambu bag and started manually ventilating. 1 squeeze, 2, 3. Nothing happened. Sarah's heart was hammering against her ribs. She'd been wrong. She'd just assaulted a corpse in front of the entire surgical team, and now Caldwell was going to have her fired and arrested, and... The general's chest rose. Not from the bag. From his own lungs. A violent, gasping inhale that sounded like someone breaking through the surface of deep water. "Holy shit," the surgical resident breathed. Sarah repositioned the tube one more time, making sure it was centered and clear. Then she stepped back and let the anesthesiologist take over, watching the monitors like a hawk. For 5 seconds, nothing changed. Then the flatline monitor suddenly hiccuped. 1 beep, 2 beeps, 3. The rhythm was erratic and weak, but it was there. "I've got a pulse," the anesthesiologist said, his voice climbing an octave. 40 beats per minute. 50. 60. The oxygen saturation started climbing. 72%. 78. 83. Dr. Voss stumbled backward, his blood-covered hands raised like he was surrendering to an invisible enemy. One of the nurses made a sound that was half laugh, half sob. The surgical resident just stood there with his mouth open, staring at the monitors like they were showing him a magic trick. Caldwell hadn't moved. He was standing perfectly still, his face absolutely white, watching Sarah Brennan, the combat nurse he'd spent 6 months humiliating, bring a dead general back to life. Sarah's legs felt like water. The adrenaline was starting to crash, and her hands were shaking so badly she had to grip the instrument tray to stay upright. She'd just performed an emergency airway intervention without authorization during a code on a three-star general, and she had no idea if she'd just saved her career or destroyed it. The general's oxygen saturation hit 90%, 94, 97. His eyelids fluttered. "He's waking up," the anesthesiologist said, scrambling to adjust the sedation. "I need to redose." "Wait," Sarah said quietly. Everyone looked at her. She moved closer to the general's head, watching his face. His eyes were moving beneath the closed lids, rapid eye movement, consciousness returning. General Marcus Holloway's eyes opened. They were unfocused and clouded with pain, but they were open, alive, aware. He looked directly at Sarah. His lips moved, trying to form words around the endotracheal tube, but no sound came out. Sarah had seen that look 1,000 times in Syria, soldiers waking up mid-surgery, terrified and confused, trying to understand why they were still alive. "You're okay," Sarah told him, her voice steady despite the tremor in her hands. "You're at Thornfield Military Hospital. You were injured, but you're safe now." The general's eyes held hers for another moment. Then they closed again as the sedation pulled him back under. But he'd been awake, conscious, alive. The operating room stayed frozen in absolute silence for what felt like an eternity. Then Dr. Voss let out a shaky breath and said, "Someone get the chief of staff down here. Right now." Gut. The corridor outside operating room 3 looked like a war zone. Sarah pushed through the doors at 0524 hours to find 30 soldiers packed into the hallway, some sitting against the walls with their heads in their hands, others standing rigid at attention with tears streaming down their faces. Military police were trying to maintain order, but grief had turned the space into chaos. A colonel saw her emerge and immediately straightened. "Nurse, is the general?" "Alive," Sarah said. The word detonated through the hallway like a grenade. For a second, nobody moved. Then the colonel's knees buckled, and he had to grab the wall for support. A sergeant let out a sound that was half shout, half prayer. 2 younger soldiers just collapsed against each other, sobbing. "He was dead," one of them said, his voice breaking. "They said he was dead." Sarah's throat was tight. "He's not dead, he's stable." The hallway erupted. Soldiers were shouting, crying, grabbing each other. Someone started singing the opening line of the army song before his voice cracked and he broke down completely. The military police didn't even try to restore order. Half of them were crying too. Sarah pushed through the crowd, her scrubs still covered in the general's blood, and made it to the nurse's station before her legs finally gave out. She sat down hard in one of the rolling chairs and pressed her palms against her eyes, trying to stop her hands from shaking. She'd done it. She'd actually done it. She'd brought a man back from clinical death by trusting her instincts over the entire surgical team's expertise, and she had absolutely no idea what happened next. What happened next was an investigation. By 0600 hours, Thornfield Military Hospital was locked down tighter than a combat zone. Armed guards stationed at every entrance. All staff confined to the building. Cell phones confiscated. A 3-star general had nearly died on the operating table, and someone was going to answer for it. Sarah spent 2 hours sitting in a windowless conference room while a military attorney asked her the same questions over and over again. "Walk me through your decision-making process one more time, Ms. Brennan. Why did you override the attending surgeon's authority? Did anyone instruct you to intervene? Were you aware that performing unauthorized medical procedures during a code situation violates hospital protocol?" Sarah answered every question the same way she'd answered them the first time, calmly, precisely, with zero emotion. She explained the wheeze, she explained the displacement. She explained her training in Syria and why she'd recognized the airway compromise when nobody else had. What she didn't explain was how it felt to spend 4 hours watching a man die while the people who were supposed to save him ignored her. The attorney finally closed his notebook. "You understand this is going to result in a formal review?" "Yes, sir." "You may have saved the general's life, Ms. Brennan, but you also violated chain of command during a critical emergency, and that has consequences." Sarah met his eyes. "I understand." She didn't care about the consequences. General Holloway was alive. That was the only thing that mattered. The attorney left, and Sarah was alone in the conference room for another 20 minutes before the door opened again. Dr. Preston Caldwell walked in. He looked like he'd aged 10 years in the last 6 hours. His surgical scrubs were gone, replaced by slacks and a button-down shirt that was wrinkled like he'd pulled it straight from his locker. His silver hair was disheveled. His hands were shaking slightly. He sat down across from Sarah and stared at her for a long moment. "I could have you fired," he said finally. Sarah didn't flinch. "Yes, sir." "I could have your nursing license suspended. I could make sure you never work in a hospital again." "I know." Caldwell's jaw worked like he was chewing on broken glass. "You made me look like a fool in front of my entire surgical team." "That wasn't my intention." "Wasn't it?" Caldwell's voice rose. "You've been here 6 months, Brennan. 6 months of barely speaking, barely participating, acting like you're too good for hospital medicine. And then tonight you waltz into my operating room and publicly humiliate me." "I saved a man's life," Sarah interrupted quietly. The words hung in the air like an accusation. Caldwell's face went red. "We would have figured it out." "When?" Sarah leaned forward, her voice still calm but her eyes hard. "When would you have figured it out, Dr. Caldwell? After another minute? 2 minutes? 5? How long does a brain survive without oxygen? Because I'm pretty sure they taught you that in medical school." Caldwell stood up so fast his chair scraped across the floor. "You don't get to talk to me like that. Then how should I talk to you?" Sarah stood too, and suddenly all the exhaustion and fear and rage she'd been holding back for 6 months came pouring out. "Should I use small words so you understand me? Should I apologize for having field experience that your prestigious residency program didn't teach you? Should I thank you for spending half a year treating me like I'm too stupid to notice when a patient is dying right in front of us?" Caldwell's mouth opened, but no sound came out. Sarah's hands were clenched at her sides. "You told me I was thinking like a field medic instead of a professional nurse." "You were right. I was thinking like someone who's watched soldiers die from blocked airways because nobody stopped to listen. I was thinking like someone who learned that arrogance kills patients faster than any injury ever could. I am not arrogant. You let a man die because you were too proud to listen to a nurse," Sarah said flatly. "What would you call that?" The color drained from Caldwell's face. For a moment, he looked like he was going to argue. Then something in him seemed to collapse. He sat back down slowly, his hands gripping the edge of the table. "He was dead," Caldwell said quietly. "I called time of death, and you brought him back." Sarah didn't respond. Caldwell looked up at her, and for the first time since she'd met him, there was no condescension in his expression, just exhaustion and something that might have been shame. "How did you know?" he asked. Sarah sat back down. "I didn't know. I suspected. There's a difference. But you were certain enough to override me. I was certain enough to try." Sarah met his eyes. "In the field, we didn't have the luxury of being certain. We made calls based on incomplete information and hope. Sometimes we were wrong, but at least we tried." Caldwell was quiet for a long time. Then he said, "I trained at Johns Hopkins. Top of my class. Published 12 papers on cardiovascular trauma. I've performed over 3,000 surgeries." His voice cracked slightly. "And tonight, a nurse with a correspondence degree knew more than I did." Sarah wanted to feel vindicated. She wanted to feel satisfied that Caldwell was finally admitting he'd been wrong. Instead, she just felt tired. "It wasn't about knowing more," she said. "It was about listening differently. You were listening to the monitors and the protocols. I was listening to the patient." Caldwell rubbed his face with both hands. When he looked up again, his eyes were red. "The general is stable," he said. "Critical condition, but stable. The chief of staff wants a full incident report by noon." "I'll write it." "They're going to investigate both of us, Brennan. They're going to pull every surgery I've performed in the last year. They're going to review every complaint that's ever been filed against me." He laughed bitterly. "And I'm betting there are a lot of those." Sarah didn't confirm or deny it, but they both knew it was true. Caldwell's treatment of nurses and junior staff had been an open secret at Thornfield for years. People complained quietly. Nothing ever changed. Until tonight. "What happens now?" Sarah asked. Caldwell stood up slowly. "Now you go home and get some sleep. And I go explain to the hospital board why the nation's most decorated combat general almost died under my care." He walked to the door, then paused with his hand on the handle. "For what it's worth," he said without turning around, "you were right about everything." Then he was gone, and Sarah was alone again. Chanta sub. She didn't go home. Instead, Sarah found herself standing outside the ICU where they'd moved General Holloway after stabilizing him in the OR. She wasn't supposed to be there. The entire floor was restricted to authorized personnel only, and Sarah definitely didn't have authorization. But the MP guarding the door was a young corporal who'd been one of the soldiers crying in the hallway earlier. When he saw Sarah approach, his eyes went wide. "You're the nurse," he said. "The one who saved him." Sarah shook her head. "I just did my job." "Ma'am, with all due respect, that's horseshit." The corporal glanced around, then lowered his voice. "My squad was in Kandahar 2 years ago. The general pulled us out of an ambush personally, flew in on a goddamn helicopter while we were pinned down and carried 3 wounded guys to the evac zone himself. He's the reason half my unit is still alive." Sarah's throat tightened. "So if you want to go in there," the corporal continued. "I didn't see anything." He stepped aside. Sarah hesitated, then nodded and pushed through the door. The ICU was dim and quiet, except for the soft beeping of monitors. General Holloway was in the far bed, surrounded by enough medical equipment to run a small field hospital. His chest rose and fell steadily with the ventilator's rhythm. IV lines snaked into both arms. Bandages covered most of his upper body. But he was alive. Sarah stood at the foot of the bed for a long time, just watching him breathe. She'd spent 4 years in Syria keeping soldiers alive long enough to reach real hospitals. She'd always wondered what happened to them after they left her care, whether they survived, whether they recovered, whether saving them had meant anything. Now she knew. "You don't look like a hero." Sarah spun around. A woman was sitting in the shadows near the window, late 50s, iron gray hair pulled back in a severe bun, wearing a general's uniform with enough ribbons to cover her entire chest. Her eyes were sharp and calculating, and they were fixed on Sarah with unsettling intensity. "General Patricia Reeves," the woman said, standing. "Chief of Staff, Thornfield Military Hospital." Sarah straightened instinctively. "Ma'am." Reeves walked closer, studying Sarah like a predator, deciding whether something was prey or competition. "You're Sarah Brennan, the nurse who defied Dr. Caldwell's direct orders during a code situation." "Yes, ma'am." "The nurse who performed an unauthorized airway intervention on a 3-star general." "Yes, ma'am." "The nurse who brought a man back from clinical death by trusting her instincts over 15 years of surgical expertise." Sarah held the general's gaze. "Yes, ma'am." Reeves was quiet for a moment. Then she said, "Do you understand the position you've put me in, Ms. Brennan?" "I imagine it's complicated." "Complicated?" Reeves laughed, but there was no humor in it. "You just exposed catastrophic negligence in my trauma department. You publicly humiliated my chief surgeon, and you did it by violating every protocol we have for chain of command during emergency procedures." Sarah's stomach dropped. "If I follow protocol," Reeves continued, "I have to suspend you pending investigation. I have to launch a formal inquiry into Caldwell's surgical competence. I have to explain to the Pentagon why one of their most decorated generals nearly died because my staff couldn't perform basic airway management." She stepped closer. "But if I follow protocol, I also have to acknowledge that you saved General Holloway's life when nobody else could, which means I'd be disciplining the one person in this entire hospital who actually did her job correctly." Sarah didn't know what to say, so she stayed silent. Reeves circled her slowly, like she was inspecting a soldier on parade. "I pulled your service record. 4 years, Syrian theater, field hospitals in Aleppo, Raqqa, Damascus, 2 commendations for Valor, 3 Purple Hearts." "Yes, ma'am." "Why did you leave combat medicine?" The question landed like a punch. Sarah's hands clenched involuntarily. "Personal reasons," she said carefully. "That's not an answer." Sarah met Reeves' eyes. "I lost people I couldn't save. Eventually, it stopped being about the ones I saved and started being about the ones I didn't. So I transferred." Reeves studied her for a long moment. Then she nodded slowly, like Sarah had just passed some kind of test. "I'm reassigning you," Reeves said. Sarah's heart sank. "Ma'am," to General Holloway's recovery team, effective immediately. Sarah blinked. "What?" "You kept him alive once," Reeves said. "You're going to keep doing it until he's well enough to tell me himself why my entire surgical department failed him." Sarah's mind was racing. "Dr. Caldwell." "Dr. Caldwell is being placed on administrative leave pending investigation. Dr. Voss will assume interim leadership of the trauma unit." Reeves's expression was unreadable. And you, Ms. Brennan, are going to do exactly what you did tonight. You're going to watch General Holloway like a hawk, trust your instincts, and speak up when something's wrong. Think you can handle that? Sarah's throat was tight. Yes, ma'am. Good. Reeves walked toward the door, then paused. One more thing. The general woke up briefly about an hour ago. First thing he said was, "Where's the nurse who saved me? Seems you made an impression." She left before Sarah could respond. Sarah stood alone in the ICU, staring at General Holloway's unconscious face, trying to process what had just happened. 6 months of being invisible, and now suddenly she was being assigned to the most high-profile patient in the entire military medical system. She should have felt relieved, vindicated, proud. Instead, she felt exposed, because now everyone was watching her. And if General Holloway took a turn for the worse on her watch, it wouldn't matter that she'd saved him once. They'd crucify her for failing him twice. By noon, the story had leaked. Sarah had no idea how. The hospital was supposed to be locked down, all communications restricted. But somehow, the press got hold of it. General Holloway survives near-death experience at military hospital. Combat nurse defies orders to save dying general. Miracle recovery raises questions about Thornfield surgical protocols. The hospital administration went into full damage control mode. Public affairs officers swarmed the building. Armed guards turned away reporters at the gates. General Reeves issued a terse statement confirming that General Holloway was stable and receiving excellent care, with no mention of what had actually happened in that operating room. But the soldiers knew, and the soldiers talked. By the time Sarah reported to the ICU for her first shift on Holloway's recovery team, there were 36 soldiers camped outside the building. Some were holding signs that said, "Thank you, Nurse Brennan." Others were just sitting in silence, keeping vigil for their general. The corporal from earlier saluted her when she arrived. "They're here for you," he said. Sarah felt her face burning. "They shouldn't be." "With respect, ma'am, they'll be here whether you want them to or not." Sarah pushed through the doors before she could embarrass herself. The ICU was running on skeleton crew, just 2 nurses and a rotating physician covering all 6 beds. Sarah's assignment was singular, General Holloway. 24-hour monitoring, full documentation, immediate escalation of any changes in condition, no pressure. She settled into the chair beside his bed and pulled out the chart. The general had been unconscious for most of the day, kept under deep sedation while his body recovered from the trauma. Vitals were stable. Oxygen levels good. No signs of infection yet, though that could change quickly with this much tissue damage. Sarah checked his pupils, checked his breath sounds, checked the surgical sites for bleeding or discharge. Everything looked okay, which meant she had nothing to do but sit and wait and try not to think about the fact that her entire career now depended on this one man's survival. Hours passed in silence. Sarah documented every vital sign change, every medication dose, every slight shift in the general's condition. It was tedious work, the kind of nursing that required constant vigilance, but very little actual intervention. She was good at it. At 1800 hours, the general's sedation began to lighten. His vitals picked up slightly. Heart rate climbing from 68 to 74, respiratory rate increasing. Sarah noted the changes and prepared for him to wake up. His eyes opened at 18:23 hours. Confused at first, scanning the room like he was trying to remember where he was. Then his gaze found Sarah, and something in his expression sharpened. He tried to speak, but the endotracheal tube was still in place. "Don't try to talk," Sarah said quietly. "You're intubated. You were injured 2 days ago during a classified operation. You're at Thornfield Military Hospital." The general's eyes held hers, and Sarah saw the exact moment he remembered. The mission, the explosion, the emergency transport, dying on the operating table. His hand moved slightly, and Sarah understood. She pulled out a notepad and pen and placed them in his palm. The general's handwriting was shaky but legible. "How bad?" 17 pieces of shrapnel removed, Sarah said. Repaired subclavian artery, patched lung. You lost a lot of blood, but the surgeons controlled it. You're going to recover. The general wrote again. I died. Sarah hesitated, then nodded. For 93 seconds. You brought me back. I corrected an airway issue. The general's eyes narrowed slightly and he wrote, Don't downplay it. Sarah didn't know how to respond to that, so she just nodded again. The general stared at her for a long moment. Then he wrote one more line and held it up. "Thank you." Sarah's throat closed up. She'd spent 4 years in Syria saving soldiers and had never once been thanked directly by any of them. They were always unconscious or delirious or shipped out before they could speak. She'd made peace with that. Combat medicine wasn't about gratitude, it was about doing the job. But seeing those two words written in a dying general's shaky handwriting hit her harder than she'd expected. "You're welcome, sir," she managed. The general's eyes closed again, exhaustion pulling him back under. Sarah sat in silence for a long time, staring at the notepad. She'd saved General Marcus Holloway's life, and now the entire military was watching to see what came next. What came next was a firestorm. The investigation into General Holloway's near death started quietly. A few meetings, some paperwork, routine interviews with surgical staff. But by the third day, when a junior nurse anonymously leaked details about Caldwell's history of dismissing field medics, the whole thing exploded into something nobody could contain. Sarah watched it happen from her chair beside the general's ICU bed. She didn't participate, didn't comment, didn't defend herself or accuse anyone. She just showed up for her shifts, monitored Holloway's vitals, documented everything, and tried to stay invisible. But invisible was no longer an option. On day 4, a congressional aide showed up asking questions about military hospital protocols. On day 5, 3 journalists camped outside the hospital gates demanding interviews. On day 6, the Secretary of Defense's office called General Reeves directly. And after that phone call, Reeves looked like she'd aged a decade. The story was national news now. Not because a general had almost died, generals died in combat all the time, but because he'd almost died in an American hospital, surrounded by the country's best surgeons, and the only person who'd saved him was a nurse that those same surgeons had spent months treating like garbage. It was the kind of scandal that ended careers. Sarah kept her head down and focused on her patient. General Holloway was extubated on day 7, awake and alert, but still weak as hell. The shrapnel wounds were healing slowly, complicated by infection risk and the sheer amount of tissue damage. He needed another surgery to clean out dead tissue from the lung repair. His pain management was a constant battle, enough medication to keep him functional, not so much that it slowed his breathing. Sarah handled all of it with the same calm efficiency she'd used in Syrian field hospitals. Check vitals, adjust meds, document changes, escalate problems before they became emergencies. The general watched her work with those sharp, calculating eyes that had probably planned 100 military operations. Sometimes he asked questions. Sometimes he just observed. But he was always paying attention. "You don't talk much," he said one afternoon while Sarah was changing his IV bag. "No, sir. Most nurses won't shut up, always chattering about the weather or their kids or what they're making for dinner." Sarah didn't respond to that. Holloway smiled faintly. "You make people uncomfortable when you're quiet. You know that?" "Yes, sir." "Good. Never change it." He shifted slightly, wincing at the pain in his chest. "Caldwell came to see me yesterday." Sarah's hands paused on the IV line. "I wasn't aware of that, sir." "Reeves authorized it. 15 minutes, supervised." Holloway's expression was unreadable. He apologized. Said he'd failed me. Said he'd failed his entire team. Sarah finished adjusting the IV and made a note on the chart without commenting. "You want to know what I told him?" Holloway asked. "That's between you and Dr. Caldwell, sir." "I told him he was right." Holloway's voice was quiet but sharp. "He did fail me, and now he gets to live with that knowledge for the rest of his career." Sarah met his eyes briefly, then looked away. Holloway was silent for a moment. Then he said, "How many soldiers did you lose in Syria?" The question hit Sarah like a physical blow. Her jaw tightened. "I'm not trying to be cruel," Holloway continued. "I'm asking because I need to understand who saved my life." Sarah set down the chart carefully. 43 confirmed, probably more that I never knew about. Out of how many treated? 612. Holloway did the math instantly. That's a 93% survival rate in a combat zone. That's exceptional. It didn't feel exceptional when the other 7% died. "No," Holloway agreed. "I imagine it didn't." He studied her for a long moment. "Is that why you left?" Sarah's throat was tight. She didn't answer. "You can tell me it's none of my business," Holloway said, "but I've commanded soldiers for 30 years, and I recognize combat fatigue when I see it. You didn't burn out. You broke. Sarah's hands were shaking. She clenched them into fists. There was a transport convoy, she heard herself saying. 7 wounded. We were evacuating them to a hospital in Turkey. Ambush hit us 20 miles outside Raqqa. RPG took out the lead vehicle. I had 3 soldiers bleeding out in the back of a truck while insurgents were shooting at us from both sides. She stopped, her voice catching. Holloway didn't push. He just waited. I saved 2 of them, Sarah continued. The third one, Private First Class James Kerrigan, 19 years old from Wisconsin, he had a femoral artery bleed that I couldn't control. I tried everything. Tourniquets, pressure, hemostatic agents. Nothing worked. He bled out in my arms while I was still trying to clamp the artery. Her eyes were burning, but she refused to cry. Afterward, the investigation concluded I'd done everything correctly. They said Kerrigan's injury was non-survivable, that no field medic could have saved him. They gave me a commendation. Sarah's voice turned bitter. A commendation for watching a kid die while I failed to stop it. So you transferred, Holloway said quietly. I transferred. Sarah looked at him directly. I told myself that hospital medicine would be different. Controlled environments, better equipment, actual support staff. No insurgents shooting at me while I tried to work. I thought it would be easier. And was it? Sarah laughed, but there was no humor in it. I spent 6 months being treated like I was too stupid to notice when someone's dying. So, no, sir. It wasn't easier. It was just a different kind of hell. Holloway was quiet for a long time. Then he said, Kerrigan's death wasn't your fault. I know that intellectually, but you don't believe it. Sarah didn't answer, which was answer enough. Holloway shifted in the bed, wincing again. I've lost 462 soldiers under my command. I remember every name, every face, every detail of how they died. And I'll carry that weight until the day I die. His voice was steady but hard. But I also remember the thousands I kept alive. The missions that succeeded because I made the right call. The families who still have their sons and daughters because I did my job. He looked at Sarah with an intensity that made her want to look away. You saved 612 soldiers in a war zone, Brennan. You brought me back from clinical death when the best surgeons in the country had given up. Stop punishing yourself for the ones you couldn't save and start accepting credit for the ones you did. Sarah's vision blurred. She blinked hard and turned back to the monitors, using the excuse of checking his vitals to hide her face. Yes, sir, she managed. Holloway let the moment pass. Then he said, When I'm recovered, I'm requesting you for my personal medical team. Sarah's head snapped up. Sir, I'm not qualified. You're the most qualified person I've met. Holloway's tone left no room for argument. And when this investigation is over and Caldwell's career is finished and Thornfield's entire trauma department gets restructured, I want you somewhere you'll actually be listened to. Sarah opened her mouth to protest, then closed it. Because she didn't know what to say to that. Before she could figure it out, alarms started screaming from the bed 3 spaces down. Sarah moved on pure instinct, crossing the ICU in seconds. The patient was a colonel who'd come in 2 days earlier with a post-surgical infection. Stable condition, routine recovery. Now his monitor showed a heart rate of 168 and blood pressure crashing. The on-duty physician was nowhere in sight. Sarah hit the code button and started assessing. Airway clear, breathing rapid and shallow, circulation failing. The colonel's skin was gray and covered in cold sweat, septic shock. I need pressors now, Sarah barked at the other nurse, who was frozen at the supply cabinet. Norepinephrine, start at 0.05 mics per kilo per minute, and get me the crash cart. The nurse scrambled to follow orders while Sarah checked the colonel's IV access. Both lines were patent. She grabbed a bag of normal saline and hung it wide open, trying to stabilize his pressure before his organs started shutting down. The physician finally ran in, a young resident who looked about 12 years old. What happened? He gasped. Septic shock, Sarah said without looking up. Probably from the surgical site infection. I need blood cultures, a lactate level, and antibiotics started within the next 5 minutes or we're going to lose him. The resident stared at her. You can't just... I'm the attending... Then attend, Sarah snapped. Or get out of my way and let me do it. The resident's face went red, but he started calling orders. Blood cultures. Lactate. Broad-spectrum antibiotics. Everything Sarah had already listed. The colonel's pressure stabilized slightly as the pressors kicked in, but he was still critical. Sarah stayed at his bedside, monitoring every vital sign, adjusting drips, calling for additional medications as needed. It took 40 minutes to get him stable enough to transfer to intensive care. When it was over, Sarah's scrubs were soaked with sweat, and her hands were shaking from adrenaline. The young resident looked like he'd just survived a war. "How did you know?" he asked, his voice shaky. "How did you know it was sepsis before I even got here?" Sarah was too tired to sugarcoat it. "Because I've seen it before. A lot. And because I was paying attention." She walked back to Holloway's bedside, expecting him to be asleep after all the commotion. Instead, he was sitting up slightly, watching her with an expression she couldn't read. "What?" Sarah asked. "That's the second time I've watched you save someone's life," Holloway said quietly. "And both times, you made it look easy. It's not easy." "I know. That's what makes it impressive." He settled back against the pillows. "I meant what I said earlier, Brennan. When this is over, I'm pulling you out of this hospital. You're wasted here." Sarah didn't know whether to feel flattered or terrified. Probably both. She was saved from responding by General Reeves walking into the ICU, her face grim. "Miss Brennan," Reeves said, "my office. Now." Reeves' office was on the 4th floor, behind 2 security checkpoints and a secretary who looked like she could kill someone with a stapler. Sarah followed the general inside and stood at attention while Reeves closed the door. "Sit," Reeves ordered. Sarah sat. Reeves walked to the window and stared out at the hospital grounds for a long moment. Then she said, "The Pentagon is shutting down the investigation." Sarah's stomach dropped. "Ma'am?" Official conclusion. General Holloway's cardiac arrest was caused by unforeseeable complications from blast trauma. Dr. Caldwell and his team performed admirably under extreme circumstances. No negligence found, no protocol violations. Everyone involved receives commendations for their service. Sarah felt like she'd been punched in the chest. "That's not what happened." "I know what happened," Reeves said, her voice hard. "I read every statement. I reviewed the entire surgical recording. I personally interviewed 12 staff members. I know exactly what happened in that operating room." "Then why?" "Because the Pentagon doesn't want a scandal." Reeves turned to face her, and Sarah saw barely controlled fury in her eyes. "They don't want headlines about military surgeons being incompetent. They don't want congressional hearings about toxic culture in military hospitals. They don't want the public losing confidence in military medicine. So they're burying it." Sarah's hands clenched on the armrests. "And Caldwell? Quietly retiring at the end of the year. Full pension, honorable discharge. He'll probably get a position at some private hospital where nobody knows his history." "That's not justice." "No," Reeves agreed. "It's politics." Sarah stood up, her voice shaking with rage. "General Holloway almost died because Caldwell was too arrogant to listen to a nurse. How many other patients has he failed? How many other people have died because nobody wanted to make waves?" "I don't know," Reeves said quietly, "but we're going to find out." Sarah blinked. "What?" Reeves pulled a folder from her desk and handed it to Sarah. "This is a full review of Caldwell's surgical history for the past 5 years. Mortality rates, complication rates, complaints filed by nursing staff. All the data that should have triggered an investigation years ago, but somehow never did." Sarah opened the folder. Her blood went cold. Caldwell's mortality rate was nearly double the national average for his specialty. 17 formal complaints filed by nurses and surgical techs, all dismissed as personality conflicts. 6 patients who died from complications that the reports described as unexpected, but that looked suspiciously like misdiagnoses or delayed interventions. "This is a pattern," Sarah said, her voice hollow. "Yes, and now it's documented." Reeves's expression was granite. The Pentagon can bury Holloway's case, but they can't bury 5 years of evidence without it looking like a cover-up. So here's what's going to happen. You're going to give me a formal statement detailing everything you observed during Holloway's surgery. Every detail, every interaction, every moment where Caldwell ignored your clinical judgment. He'll deny it. He can deny it all he wants. But the surgical recording doesn't lie. And neither do 12 other staff members who are ready to testify that Caldwell has been doing this for years. Sarah's mind was racing. You're building a case. I'm building accountability. Reeves leaned forward. The Pentagon wants to protect their reputation. Fine, but I'm not protecting Caldwell. That man has been killing patients through negligence and arrogance for half a decade, and I'm done watching it happen. What do you need from me? Your statement. Detailed, clinical, irrefutable. Then I need you to keep doing exactly what you've been doing. Take care of General Holloway, save lives when nobody else can, and let the system see what real competence looks like. Sarah felt something shift in her chest. This wasn't about vindication anymore. This was about every nurse who'd ever been dismissed, every patient who'd died because someone in power refused to listen, every person who'd tried to speak up and been silenced. I'll write the statement, Sarah said. Good. Reeves stood. One more thing. When this breaks, and it will break, you're going to be in the spotlight. The press is going to want interviews. Other nurses are going to want you to be their spokesperson. Politicians are going to try to use your story for their agendas. You need to be ready for that. Sarah's throat was tight. I just wanted to do my job. And you did. Better than anyone in this building. Reeves' expression softened slightly. But now your job is bigger than just patient care. Whether you wanted it or not, you're the face of this fight. So decide now if you're ready to stand up and be counted. Sarah thought about Private Kerrigan bleeding out in her arms, about the 43 soldiers she'd lost and the 600 she'd saved, about General Holloway writing thank you in shaky handwriting, about every single time Caldwell had dismissed her observations, and every patient who'd suffered because of it. I'm ready, she said. The statement took Sarah 3 days to write. She documented everything. The wheeze she'd heard, the warnings she'd given, Caldwell's dismissals, the airway displacement, the resuscitation. She included timestamps, direct quotes, clinical observations. She wrote it like a combat after-action report. Factual, detailed, irrefutable. When she finished, it was 47 pages long. Reeves read it in one sitting, then looked up with grim satisfaction. This is going to destroy him, she said. Sarah felt no triumph, just exhaustion. But the statement was only the beginning. Within a week, 3 more nurses came forward with their own stories about Caldwell. A surgical tech reported that Caldwell had ignored his warning about a contaminated instrument, resulting in a post-op infection that nearly killed the patient. An anesthesiologist described how Caldwell had dismissed his concerns about a patient's airway during a different surgery, leading to a code situation that could have been prevented. The pattern was undeniable. Reeves compiled everything into a comprehensive report and sent it to the Inspector General's office. Not through normal channels, not through the Pentagon's bureaucracy. Directly to the IG, with copies to 3 different congressional oversight committees. The Pentagon couldn't bury it this time. The investigation was reopened within 48 hours. Not a quiet internal review. A full formal investigation with subpoena power and media scrutiny. Caldwell's retirement was suspended pending the outcome. Sarah watched it unfold from the ICU, still focused on keeping General Holloway alive. The general was improving steadily, off pressors, breathing on his own, starting physical therapy. He'd be discharged soon, transferred to a rehabilitation facility for long-term recovery. But before that happened, he had something to say. On Sarah's 14th day as his primary nurse, Holloway asked her to call General Reeves to his room. When Reeves arrived, Holloway was sitting up in bed, looking stronger than he had since the surgery. Still weak, still in pain, but present, commanding. I've been briefed on the investigation, Holloway said without preamble. I know what you're doing, Patricia, and I want to go on record. Reeves' expression didn't change. That's your right, sir. I remember that surgery, Holloway said. Not all of it, but I remember pieces. I remember hearing Ms. Brennan's voice saying something about my airway. I remember Caldwell telling her to shut up, and I remember thinking that if I survived, I was going to make sure everyone knew what actually happened in that operating room. He looked at Sarah. So here's my statement for your investigation. Dr. Preston Caldwell's negligence and arrogance nearly killed me. Nurse Sarah Brennan's competence and courage saved my life. And if the Pentagon tries to bury this again, I will personally hold a press conference and say exactly that to every journalist in the country. Reeves' eyes glinted. The Pentagon won't like that, sir. I don't care what the Pentagon likes. Holloway's voice was steel. I care about making sure this never happens to another soldier. So you take my statement, you use it however you need to, and you make damn sure that Caldwell never operates on anyone again. Yes, sir, Reeves said. She left to formally document Holloway's statement, and Sarah was alone with the general again. "You didn't have to do that," Sarah said quietly. "Yes, I did." Holloway met her eyes. "You stood up for me when nobody else would. Now I'm standing up for you." Sarah's throat was tight. "Thank you, sir." "Don't thank me yet. This is about to get ugly." He was right. The next morning, the story broke nationwide. Not because the military released it, because someone leaked Holloway's statement to the press. And suddenly every news outlet in the country was running headlines about the decorated general who'd nearly been killed by medical negligence and the combat nurse who'd defied orders to save him. The hospital was besieged, reporters camping outside the gates, camera crews trying to bribe security guards for access. Sarah's name was everywhere. Combat nurse Sarah Brennan, the woman who saved General Holloway. Military hospital scandal. Culture of silence almost kills decorated general. Pentagon. Investigation expands amid allegations of systemic negligence. Sarah stopped reading the news after the first day. It was too much, too loud, too public. She just wanted to do her job. But her job had changed. Now she was being pulled into meetings with investigators, giving depositions, reviewing surgical footage. Other nurses were approaching her in hallways, quietly thanking her for speaking up, sharing their own stories of being dismissed and ignored. It was overwhelming. And then, on day 18, everything exploded. Dr. Preston Caldwell held a press conference. Sarah watched it on the ICU television, frozen in place as Caldwell stood in front of a dozen microphones and cameras, looking calm and professional in an expensive suit. "I want to address the allegations that have been made against me," Caldwell said smoothly. "The events surrounding General Holloway's surgery have been mischaracterized and sensationalized. The truth is that my surgical team performed exceptionally under extreme circumstances. We controlled massive bleeding, repaired critical injuries, and worked for hours to save the general's life." He paused, his expression grave. "During that surgery, Nurse Brennan observed something that she believed required intervention. She communicated that observation, and I made a clinical judgment to prioritize other life-threatening issues first. That's how trauma surgery works. Constant triage, constant decision-making under pressure. Ms. Brennan disagreed with my priorities. That disagreement has now been twisted into a narrative of negligence, which is simply false." Sarah's hands were shaking. "I have dedicated my entire career to saving lives," Caldwell continued. "I have performed over 3,000 successful surgeries. I have trained dozens of surgeons who are now serving across the military. And yes, I have lost patients. Every surgeon has. But to suggest that those losses were caused by negligence or arrogance is not only untrue, it's defamatory." He looked directly into the camera. "I respect Ms. Brennan's service in Syria. I respect her dedication to patient care, but I cannot accept being made a scapegoat for a system that failed General Holloway. The truth will come out in the investigation, and when it does, I believe I will be fully vindicated." The press conference ended, and Sarah stood in the ICU with her heart pounding and her mind racing. Caldwell had just called her a liar on national television, and suddenly she wasn't sure anyone would believe her story anymore. The ICU went dead silent. Sarah stared at the television screen where Caldwell's face was frozen in mid-sentence, his expression perfectly calculated to look wounded and dignified. Every nurse in the room was looking at her now, waiting to see how she'd respond to being publicly called a liar by the man who'd almost killed a general. She didn't respond. She turned off the television, picked up General Holloway's chart, and went back to work. But her hands were shaking so badly she could barely write. Within an hour, her phone started exploding with messages. Reporters requesting comment, colleagues asking if she was okay, anonymous numbers sending threats, some supporting Caldwell, some supporting her, all of them vicious. Sarah turned off her phone and shoved it in her locker. General Reeves appeared in the ICU 30 minutes after Caldwell's press conference ended. "Don't," she said before Sarah could speak. "Don't respond, don't engage, don't give him the satisfaction. He called me a liar on national television. He's scared." Reeves's voice was hard. "He knows the investigation is closing in, so he's trying to control the narrative. Let him. Because when the evidence comes out, his performance today is going to make him look even worse." Sarah wanted to believe that, but doubt was creeping in now, cold and insidious. Caldwell was a respected surgeon with 15 years of experience and a prestigious background. She was a combat nurse with a correspondence degree and a history of PTSD. Who would the public believe? The surgical recording, Sarah said quietly. You said it doesn't lie. It doesn't. Then release it. Show everyone what actually happened in that operating room. Reeves shook her head. The IG has it sealed pending the investigation. I can't release it without authorization, and authorization won't come until the investigation concludes. How long will that take? Weeks, maybe months. Reeves met Sarah's eyes. I know that's not the answer you want, but this is how the system works. Slow, methodical, frustrating as hell. Sarah felt something break inside her chest. She'd done everything right. She'd told the truth. She'd saved a man's life, and now she had to sit in silence while Caldwell twisted the story and destroyed her credibility. I can't do this, she said, her voice cracking. Yes, you can, Reeves said firmly, because you're not alone. Holloway believes you. I believe you. 12 other staff members believe you. And when that recording gets released, the entire country will believe you. But Sarah wasn't sure she believed herself anymore. The next 72 hours were brutal. Caldwell's press conference shifted public opinion hard. Social media exploded with debates about military medical protocols, combat nurses versus traditional surgeons, whether Sarah had overstepped her authority. Half the comments supported her. The other half called her everything from attention-seeking to delusional. Medical professionals started weighing in. Some defended Caldwell's surgical decisions. Others praised Sarah's clinical instincts. The debate got technical and vicious, with both sides accusing the other of incompetence. Sarah stopped reading the news entirely, stopped checking her phone, stopped engaging with anyone outside the ICU. She just focused on General Holloway, who was recovering faster than expected. His strength was returning. His pain was manageable. He was walking short distances with assistants now, preparing for transfer to the rehabilitation facility. But he was watching her closely, and Sarah knew he could see her unraveling. You're not sleeping, he said one morning while she was checking his vitals. I'm fine, sir. That's not what I asked. Holloway's voice was gentle but firm. I asked if you're sleeping, and based on those circles under your eyes, I'm guessing the answer is no. Sarah didn't respond. Caldwell's press conference got to you, Holloway said. It doesn't matter. It does matter, because you're starting to doubt yourself, and that's exactly what he wants. Holloway shifted in the bed, his expression serious. I've dealt with men like Caldwell my entire career. Arrogant, calculating, willing to sacrifice anything to protect their reputation. They're dangerous because they're good at making other people question reality. Sarah's jaw was tight. What if he's right? What if I overstepped? Did you believe my airway was compromised? Yes. Did you communicate that to the surgical team? Yes. Did they listen? Sarah's hands clenched. No. Then you didn't overstep. You did your job. Holloway's voice was steel now. And I'm alive because you refused to be silenced. Don't let that bastard take that away from you. Sarah felt tears burning in her eyes, but she blinked them back. What if the investigation doesn't find anything? What if they decide he was right and I was wrong? Then we'll deal with that when it happens, Holloway said. But until then, you keep your head up and you keep doing what you do best, saving lives when nobody else can. Before Sarah could respond, her pager went off. Code Blue, Trauma Bay 2. She ran. The Trauma Bay was chaos when she arrived. Paramedics were wheeling in a young soldier, early 20s, massive chest trauma, blood everywhere. The on-duty trauma surgeon was already gowned up, barking orders at his team. Sarah grabbed a gown and gloves and jumped in without being asked. GSW to the chest, the lead paramedic reported. Entry wound left anterior, no exit. Hypotensive in the field, 2 large bore IVs established. Received 2 units en route. The trauma surgeon, Dr. Marcus Webb, a solid physician who'd never given Sarah any problems, was already cutting away the soldier's uniform. Get me a chest tube kit and 4 more units of O-neg. Sarah, I need you on airway management. Sarah moved to the head of the bed and assessed. The soldier was unconscious, breathing shallow and rapid, oxygen saturation dropping. She intubated him in under 30 seconds, smooth and precise despite the chaos around her. Tubes in, she reported. Good bilateral breath sounds. Webb nodded and made the incision for the chest tube. Blood poured out immediately. Dark, venous, too much of it. He's got a major vessel injury. I need vascular in here now. But there was no vascular surgeon available. The attending was in another surgery. The backup was off-site. Webb's face went pale. I can't repair a subclavian tear. I'm not trained for that. Sarah's mind flashed back to Syria, to field hospitals where vascular surgeons didn't exist and combat medics had to do everything themselves. She'd assisted on vessel repairs dozens of times, talked through the procedures by surgeons over radio while her hands did the actual work. I can talk you through it, she said. Webb stared at her. You're a nurse. I'm a combat medic who's assisted on vascular repairs in war zones. Sarah's voice was steady. You can wait for backup and watch him bleed out, or you can let me help you save him. Webb looked at the soldier's crashing vitals, then back at Sarah. Talk fast. Sarah positioned herself where she could see the surgical field and started giving instructions. You need to get proximal and distal control first. Clamp above and below the tear to stop the bleeding. Use vascular clamps, not regular hemostats. You need smooth jaws that won't damage the vessel wall. Webb's hands were shaking, but he followed her directions. The bleeding slowed as he got the clamps in place. Good, Sarah said. Now you need to assess the damage. Is it a clean tear or is there tissue destruction around it? Webb peered into the chest cavity. Clean tear, maybe 2 centimeters long. You can repair that with a running suture. Use 5-0-proline, start at one end of the tear and work your way across. Small bites, even tension. Don't pull too tight or you'll tear the vessel worse. Webb grabbed the suture and started working. His hands were steadier now, focused on the task. Sarah watched every movement, calling corrections when needed, guiding him through the repair like she'd guided dozens of field medics in Syria. It took 23 minutes, but Webb closed the tear. Release the distal clamp first, Sarah instructed. Make sure there's no leakage. Then release the proximal. Webb released the clamp slowly. No bleeding. The repair held. The soldier's blood pressure started climbing. Oxygen saturation improved. Heart rate stabilized. Webb stepped back from the table, his face white. That was exactly what needed to happen, Sarah finished. You saved his life. We saved his life, Webb corrected. He looked at her with something like awe. How the hell did you learn to do that? 4 years in Syria, Sarah said quietly. You learn fast when there's nobody else to help. Webb stripped off his gloves and turned to his team. Someone get this soldier stable for transport to the ICU, and document that Nurse Brennan provided critical assistance during this procedure. The team moved efficiently, and Sarah helped them stabilize the patient before stepping out of the trauma bay. Her scrubs were covered in blood again. Her hands were steady, but her mind was racing. She'd just assisted on a major vascular repair, as a nurse, without direct physician supervision. If anyone wanted to go after her for overstepping her scope of practice, she'd just handed them ammunition. But the soldier was alive, and that was all that mattered. Word of the trauma bay save spread through the hospital within hours. By the next morning, 3 different physicians had approached Sarah asking for her input on complex cases. 2 surgical residents asked if she'd be willing to teach a class on field trauma management. Even the hospital administrators were looking at her differently now. Less like a liability, more like an asset. But the investigation into Caldwell was still grinding forward, and Sarah was still waiting for vindication that might never come. On day 22, everything changed. Sarah was in the ICU checking on Holloway when General Reeves appeared, her expression unreadable. Conference room, Reeves said. Both of you, now. Holloway raised an eyebrow. I'm still recovering, Patricia. This can't wait. They made their way to the 4th floor conference room, Holloway moving slowly with a cane, Sarah trailing behind with growing dread. When they arrived, the Inspector General was waiting. A sharp-eyed 2-star general named Robert Kincaid, who looked like he'd spent his entire career hunting down corruption. Sit, Kincaid said. They sat. Kincaid opened a laptop and turned it so they could see the screen. We've completed our review of the surgical recording from General Holloway's operation. What I'm about to show you is a 2-minute segment that we believe is critical to this investigation. He pressed play. Sarah watched herself on screen, standing beside the instrument table while Caldwell and his team worked on Holloway's chest. The audio was clear, too clear. She could hear herself saying quietly, Dr. Caldwell, I think there might be an airway issue. Caldwell's response was immediate and cutting. I think you might want to focus on your actual job, which is handing me instruments when I ask for them. The room went cold. Kincaid fast-forwarded 30 seconds. Sarah tried again. The airway sounds compromised. I'm hearing, Caldwell interrupted. What you're hearing is the sound of a ventilator doing its job. What I'm hearing is a nurse with 6 months of hospital experience trying to diagnose a patient during a critical operation. Do you see the problem here? Another jump forward. Sarah's voice, more insistent now. With respect, sir, I spent 4 years treating blast trauma in Syria. I've heard this exact sound before, and it means Caldwell, dripping with condescension. What it means is that you're still thinking like a field medic instead of a professional nurse. There's a reason we have hierarchies in modern medicine, Ms. Brennan. There's a reason we don't let combat medics with correspondence degrees make diagnostic calls in state-of-the-art trauma centers. Kincaid paused the video and looked at Sarah. How many times did you attempt to alert Dr. Caldwell to the airway issue? Sarah's voice was hollow. 7 times over 4 hours. And how many times did he acknowledge your concern? 0. Kincaid's expression was granite. This recording shows a pattern of deliberate dismissal of clinical observations from qualified medical personnel. It shows Dr. Caldwell prioritizing his authority over patient safety. And it shows that General Holloway's near death was not caused by unforeseeable complications. It was caused by a surgeon who refused to listen. He closed the laptop. Ms. Brennan, your statement has been corroborated by the surgical recording, by testimony from 12 staff members, and by General Holloway's own account. Dr. Caldwell's claims that you mischaracterized events are demonstrably false. Sarah felt like she couldn't breathe. Furthermore, Kincaid continued, our review of Dr. Caldwell's surgical history has revealed a pattern of similar incidents over the past 5 years. 17 formal complaints from nursing staff, 9 cases where patients suffered complications that could have been prevented if Caldwell had listened to observations from his team. 6 deaths that warrant further investigation. Holloway's hands clenched on his cane. 6? 6. Kincaid's voice was ice. Dr. Caldwell has been operating with impunity for years because previous investigations were either suppressed or inadequately pursued. That ends today. What happens now? Sarah asked, her voice shaking. Now we make this public, Kincaid said. Not through a press conference, not through carefully worded statements. We release the surgical recording, we publish the full investigation report, and we let the American people see exactly what happened in that operating room. Sarah's vision blurred. When? Tomorrow morning, 0900 hours. Reeves leaned forward. The recording shows Caldwell dismissing you repeatedly, Sarah. It shows him being condescending and unprofessional. It shows him prioritizing his ego over a patient's life. When this goes public, his career is finished, but you need to be ready for what comes next. What comes next? Sarah asked. You become the face of this scandal, Reeves said bluntly. Every news outlet in the country is going to want to interview you. Medical organizations are going to want you to speak about nursing advocacy. Politicians are going to try to use your story for healthcare reform. Your life is about to become very public, very fast. Sarah felt panic rising in her chest. I don't want that. I just want to do my job. I know, Holloway said quietly. But sometimes doing your job means standing up and being counted, whether you want the attention or not. Kincaid stood. The recording goes public tomorrow. I recommend you prepare a statement. Keep it simple, factual, professional. Don't attack Caldwell personally. The evidence will do that for you. He left, and Sarah sat in stunned silence. Tomorrow, the entire country would see proof that she'd been telling the truth. Tomorrow, Caldwell's lies would be exposed. Tomorrow, everything changed. Sarah didn't sleep that night. She sat in her apartment staring at a blank document on her laptop, trying to figure out what to say when the world started watching. She wrote a dozen different versions, deleted them all, started over. Finally, at 0400 hours, she wrote, My name is Sarah Brennan. I'm a combat nurse with 4 years of field experience in Syria and 6 months at Thornfield Military Hospital. On the night of General Holloway's surgery, I observed clinical signs that indicated an airway compromise. I reported those observations to the surgical team multiple times. Those observations were dismissed. General Holloway went into cardiac arrest as a result. I performed an emergency airway intervention that saved his life. Everything I did was in service of patient care. I stand by every decision I made that night, and I hope that sharing this story will help prevent similar situations in the future. She read it over 3 times, then deleted the last sentence. It sounded too much like she was asking for something. She rewrote it. I hope this story helps other nurses find the courage to speak up when they see something wrong. Better, more honest. She saved the document and sent it to General Reeves for review. At 0847 hours, Sarah received a text from Reeves. Perfect. Don't change a word. At 0900 hours, the Inspector General's office released the full investigation report and the surgical recording to the press. Sarah watched it happen from the ICU break room, surrounded by nurses who'd become her unlikely allies over the past month. They'd all gathered around the television, watching news anchors describe the release as explosive and damning. Then the network started playing clips from the recording. Sarah heard her own voice saying, "I think there might be an airway issue." Heard Caldwell's dismissive response. Heard herself trying again and again while Holloway died on the table. The nurses around her were crying, some from anger, some from recognition, because they'd all been dismissed by surgeons before. They'd all been talked down to. They'd all been made to feel like their observations didn't matter. One of them, a senior ICU nurse named Rita Vasquez, who'd worked at Thornfield for 15 years, put her hand on Sarah's shoulder. "Thank you," Rita said quietly, "for not staying silent." Sarah couldn't speak. She just nodded. The news coverage continued all day. Medical experts analyzed the recording. Nursing organizations issued statements supporting Sarah. Politicians called for reforms. The American public watched a decorated combat nurse get dismissed and humiliated by a surgeon who'd almost killed a general through sheer arrogance. And Caldwell's career imploded in real time. His medical license was suspended by 1,400 hours. His hospital privileges were revoked by 1,600 hours. By 1,800 hours, 3 private hospitals that had been considering him for positions had publicly withdrawn their offers. At 1923 hours, Caldwell released a statement through his attorney. "In light of the investigation's findings, I am retiring from medical practice effective immediately. I deeply regret any mistakes made during General Holloway's surgery and wish him a full recovery." It was a surrender, not an apology, not an admission of wrongdoing, just a retreat. But it was enough. Sarah read the statement in the ICU and felt nothing. No triumph, no satisfaction, just exhaustion. She'd won. But it didn't feel like winning. It just felt like surviving. Inky. General Holloway was discharged to the rehabilitation facility 3 days later. Sarah helped coordinate the transfer personally, making sure every detail was perfect. Medications reconciled, care plans documented, follow-up appointments scheduled. Holloway was walking unassisted now, still weak but recovering faster than anyone expected. On his last morning at Thornfield, he asked to speak with Sarah privately. They sat in his hospital room, empty now except for the 2 of them, and Holloway looked at her with those sharp, calculating eyes. "Caldwell's finished," he said. "Yes, sir." "You did that." "The evidence did that." Holloway smiled faintly. "Don't downplay it. You stood up to a man with power and institutional support. And you didn't back down even when it cost you everything. That takes courage most people don't have." Sarah's throat was tight. "I was just doing my job." "No," Holloway said firmly. "You were doing the right thing. There's a difference." He reached into his bag and pulled out an envelope. "This is a letter of recommendation, not for a nursing position, for a leadership role in military medical reform. General Reeves and I have been discussing creating a new oversight position, someone who can advocate for junior medical staff, review surgical protocols, and make sure what happened to me doesn't happen to anyone else." Sarah stared at the envelope. "Sir, I'm not qualified." "You're the most qualified person I know." Holloway held out the letter. "You don't have to accept, but I want you to consider it, because the military needs people like you in positions of power, people who actually give a damn about doing the right thing." Sarah took the envelope with shaking hands. Holloway stood slowly, leaning on his cane. "I'm being transferred to Walter Reed for the final phase of recovery. But I'll be back in active duty within 6 months. And when I am, I want you on my team. Think about it. He extended his hand. Sarah shook it, her voice barely above a whisper. Thank you, sir. No, Holloway said. Thank you for not giving up on me when everyone else had. He walked out of the room, and Sarah was alone again. She opened the envelope and read the letter. It was 3 pages long, detailing her qualifications, her combat experience, her clinical expertise, her courage under pressure. It was the kind of recommendation that could change a career. Sarah folded it carefully and put it in her pocket. Then she went back to work. 3 weeks later, Sarah received a call from General Reeves requesting a meeting. When Sarah arrived at Reeves' office, the general wasn't alone. Sitting across from her desk was a civilian woman in her 50s, Dr. Ellen Morrison, Deputy Director of Military Health Affairs at the Pentagon. Ms. Brennan, Morrison said, standing to shake Sarah's hand, I've been reviewing your case extensively. What you did for General Holloway and what you've exposed about systemic failures in military medicine has created an opportunity for significant reform. Sarah sat down slowly. I'm not interested in becoming a political symbol, ma'am. I'm not asking you to be a symbol, Morrison said. I'm asking you to be a leader. We're establishing a new position within military medical oversight, a patient safety advocate with direct authority to investigate complaints, review surgical outcomes, and recommend systemic changes. The position reports directly to my office, bypassing hospital politics entirely. Sarah's heart was pounding. You want me for that position? You're the only person I want for that position, Morrison said. You've proven you can stand up to institutional pressure. You've proven you can identify problems before they become catastrophic. And you've proven you care more about patients than politics. That's exactly what this position needs. Reeves leaned forward. This is a chance to make sure what happened to Holloway doesn't happen again. To give nurses and junior medical staff a voice that can't be silenced. To hold surgeons accountable when they prioritize ego over patient safety. Sarah looked between them, her mind racing. What about my clinical work? I'm a nurse. That's who I am. You'd still maintain clinical credentials, Morrison said. You'd still work with patients. But you'd also have the authority to investigate, to intervene, and to enforce accountability. It's a hybrid role, half clinical, half administrative. And it comes with a rank equivalent to lieutenant colonel. Sarah felt dizzy. 6 months ago, she'd been an invisible combat nurse nobody listened to. Now the Pentagon was offering her a position with real power to change the system. I need to think about it, she said. Take your time, Morrison said, but not too much time. We want this position filled within 60 days. The meeting ended and Sarah walked out of the building into cold Detroit air. Her mind was spinning. This was everything she'd never known she wanted: authority, influence, the power to protect other nurses from what she'd experienced. But it also meant stepping into the spotlight permanently. No more hiding, no more staying invisible. She pulled out her phone and dialed a number she'd been avoiding for weeks. Her former commanding officer from Syria answered on the second ring. Brennan, Colonel Davis McKenna said, surprise evident in his voice. I saw the news. Hell of a thing you did. I need advice, sir. Shoot. Sarah explained the Pentagon's offer. McKenna listened in silence. When she finished, he said, You scared? Terrified. Good. Means you understand what you're taking on. McKenna paused. You remember what I told you when you left Syria? Sarah's throat tightened. You said I was one of the best combat medics you'd ever seen, and that I was wasting my talent running away from what happened to Kerrigan. I meant it. You've got a gift, Brennan, not just for medicine, for seeing what other people miss, for having the guts to speak up when everyone else stays quiet. That's rare. And if you walk away from this Pentagon position because you're scared of the spotlight, you're wasting it again. Sarah closed her eyes. What if I fail? Then you fail. But at least you'll fail trying to do something that matters. McKenna's voice softened. You didn't fail Holloway. You didn't fail those 600 soldiers in Syria. You didn't even fail Kerrigan. He was gone before you touched him, and you know it. Stop punishing yourself and start using what you learned. That's the only way Kerrigan's death means anything. Sarah's vision blurred with tears. Yes, sir. You're taking the job, McKenna said. It wasn't a question. I'm taking the job. Good. Now go make those Pentagon bastards regret ever dismissing a combat nurse. The call ended and Sarah stood alone on the sidewalk, watching her breath fog in the cold air. She was terrified, but she was ready. Buckets. Sarah called Dr. Morrison the next morning and accepted the position. The announcement came 2 days later, buried in a Pentagon press release about military medical reforms, but picked up immediately by news outlets still following the Caldwell scandal. Combat nurse Sarah Brennan appointed to new military patient safety position. Pentagon creates oversight role in wake of Thornfield scandal. Nurse who saved General Holloway given authority to investigate medical negligence. The response was immediate and polarized. Nursing organizations praised the appointment. Some physician groups called it an overreach. The general public mostly seemed satisfied that someone was being held accountable. Sarah ignored all of it and focused on preparation. Morrison sent her briefing materials on current cases under review, systemic issues in military hospitals, ongoing investigations. Sarah read everything, taking notes, identifying patterns. She found 12 cases that looked suspiciously like what had happened with Caldwell. Surgeons dismissing nursing observations, patients suffering preventable complications, complaints buried by hospital administration. 12 cases. 12 potential investigations. Sarah started making a list. On her last day at Thornfield, the nursing staff threw her a quiet farewell gathering in the break room. No speeches, no formal ceremony, just coffee and donuts and 24 nurses who'd become her unexpected family. Rita Vasquez hugged her tight. "You changed everything here," she said. "We can speak up now without being afraid. You did that." Sarah's voice was thick. "You would have done the same." "No," Rita said firmly. "We wouldn't have. We were too scared." "You weren't." Sarah left Thornfield that afternoon with a box of her belongings and a weight on her shoulders that felt both crushing and necessary. She was leaving clinical nursing, at least partially, to become something else. An investigator. An advocate. A weapon against the kind of institutional arrogance that had almost killed General Holloway. She drove home, unpacked the box, and sat down at her laptop. Then she opened the first case file Morrison had sent her and started reading. It was a surgical complication at a military hospital in Texas. A nurse had reported concerning vital signs during a routine procedure. The surgeon had dismissed her observations. The patient had coded on the table and barely survived. The surgeon's name was Dr. Philip Ashworth. According to the file, he'd trained under Preston Caldwell 15 years ago. Sarah's hands tightened on the laptop. She'd thought Caldwell's downfall was the end of the story. But as she read through Ashworth's surgical history and saw the same pattern, dismissive behavior, ignored warnings, preventable complications, she realized the truth. Caldwell wasn't an isolated case. He was a symptom of something much bigger. And Sarah had just been given the authority to expose all of it. Sarah spent her first week in the new position buried in case files, and what she found made her stomach turn. Dr. Philip Ashworth wasn't just following in Caldwell's footsteps. He was worse. 23 formal complaints over 12 years, 14 preventable complications, 3 deaths that had been classified as unfortunate outcomes but showed clear evidence of surgical negligence. And just like Caldwell, every investigation had been quietly shelved or dismissed as personality conflicts. Sarah compiled everything into a preliminary report and sent it to Dr. Morrison. Morrison called her 2 hours later. "This is damning," Morrison said without preamble. "If even half of this is accurate, we're looking at systematic negligence spanning more than a decade." "It's all accurate," Sarah said. "I've cross-referenced surgical records, nursing complaints, patient outcomes. Ashworth has been operating the same way Caldwell did, dismissing staff observations, prioritizing his authority over patient safety, and getting away with it because nobody wanted to challenge a respected surgeon. Can you prove it? Give me access to the surgical recordings, and I can prove all of it." Morrison was quiet for a moment. "You understand what you're asking for. If we go after Ashworth, it's going to open the floodgates. Every negligent surgeon in the military medical system is going to be under scrutiny. We're talking about dozens of investigations, hundreds of cases, careers destroyed across the board." Sarah's voice was steady. "Good. Because those careers should have been destroyed years ago." "All right," Morrison said. I'll get you the recordings, but Sarah, be ready. This is going to get ugly." It got ugly fast. Sarah requested surgical recordings from 17 cases involving Ashworth. 13 of them showed the same pattern: nursing staff raising concerns, Ashworth dismissing them, patients suffering preventable complications. The evidence was irrefutable. She wrote a comprehensive investigation report and submitted it to Morrison with a recommendation for immediate suspension of Ashworth's medical license pending formal review. Morrison forwarded the report to the Inspector General's office. Within 48 hours, Ashworth was placed on administrative leave. Within a week, 3 more nurses at his hospital came forward with additional complaints they'd been too afraid to file before. Within 2 weeks, the investigation expanded to include 5 other surgeons who'd trained under Caldwell and showed similar patterns of negligence. The military medical system was imploding, and Sarah was the one holding the match. The backlash came from exactly where Sarah expected. Senior physicians who saw her investigations as an attack on medical authority itself. A group of military surgeons published an open letter in a medical journal, calling Sarah's appointment a dangerous precedent that undermines physician autonomy and threatens the quality of military medical care. They argued that giving a nurse investigative authority over surgeons violated the traditional medical hierarchy and would lead to frivolous complaints from disgruntled staff. Sarah read the letter in her Pentagon office and felt the old familiar anger rising in her chest. She drafted a response and sent it to Morrison for review. To the physicians who believed that accountability undermines autonomy, General Marcus Holloway was 93 seconds from brain death because a surgeon refused to listen to a nurse's clinical observations. That's not hierarchy. That's negligence. If your authority depends on silencing the people around you, then you don't deserve that authority. Patient safety isn't about protecting physicians' egos. It's about keeping people alive. And if that threatens your sense of professional superiority, then maybe you're in the wrong profession. Morrison read it and called Sarah immediately. "Don't publish that," she said. "Why not?" "Because it's going to make you a target. Those surgeons have institutional power, political connections, the ability to make your life very difficult." Sarah's jaw was tight. "They're already making my life difficult. At least this way I'm fighting back." Morrison sighed. "You're not wrong. But you need to understand, once you publish something like this, there's no taking it back. You're declaring war on the entire old guard medical establishment." "I declared war the moment I took this position," Sarah said. "I'm just making it official." Morrison was quiet for a long moment. Then she said, "All right, publish it, but be ready for the consequences." Sarah published the response that afternoon. The medical community exploded. Some physicians supported her. Most didn't. Social media erupted with debates about nursing scope of practice, physician oversight, whether Sarah was a crusader for patient safety or a dangerous radical undermining medical expertise. Sarah stopped reading the comments after the first 100 death threats, but she kept working, because 3 days after her response was published, she received an email from a surgical nurse at a military hospital in California. The email was brief. "I've been trying to report a surgeon here for 2 years. Nobody listens. Can you help?" Sarah opened the attached documentation. Another surgeon. Another pattern of dismissed warnings and preventable complications. Another case that had been buried by hospital administration. She forwarded the email to Morrison with a single line. "This is number 6. Morrison replied within an hour. "How many more do you think there are?" Sarah typed back. "Dozens. Maybe hundreds. We're only seeing the ones brave enough to come forward." Morrison's response was immediate. "Then we need to make it easier for them to come forward. I'm authorizing you to establish a direct reporting system. Any military medical staff member can file a complaint directly with your office, bypassing hospital administration entirely." Sarah stared at the email, her heart pounding. This was real power. Not just the authority to investigate individual cases, but the infrastructure to systematically expose negligence across the entire military medical system. She started building the reporting system that afternoon. The anonymous reporting portal went live 6 weeks after Sarah took the position. Within the first 24 hours, she received 47 complaints. Within the first week, 312. Within the first month, over 1,000. Sarah couldn't investigate all of them. Nobody could. But she could identify patterns. Surgeons with multiple complaints, hospitals with systemic issues, cases that showed clear evidence of negligence requiring immediate intervention. She assembled a team, 3 nurse investigators with combat experience, two physician advisors who'd been advocating for medical reform for years, an administrative coordinator to manage the incoming flood of reports. Together they started building cases. Some investigations led nowhere. Personality conflicts, misunderstandings, complaints filed in anger but lacking substance. But others revealed exactly what Sarah had feared. Surgeons who'd been operating negligently for years. Hospitals that had systematically suppressed complaints. Patients who'd died or suffered permanent harm because nobody in authority had listened to the people who'd tried to warn them. Sarah worked 16-hour days, reviewing cases, interviewing witnesses, compiling evidence. She barely slept, barely ate. The nightmares from Syria came back. Soldiers dying in her arms, blood everywhere, the feeling of helplessness when nothing she did was enough. But now she had the power to do something about it. On a cold morning in November, Sarah walked into Dr. Morrison's office with a file folder containing evidence against 12 military surgeons who'd collectively caused over 40 preventable patient deaths through negligence. Morrison read through the evidence in silence, her face growing darker with each page. "This is going to destroy careers," she said finally. "These careers should have been destroyed years ago," Sarah replied. "How many more patients have to die before we stop protecting bad surgeons?" Morrison closed the folder and met Sarah's eyes. "You're right. Submit the recommendations, all 12 of them." Sarah submitted the recommendations that afternoon. Within a week, all 12 surgeons were suspended pending formal investigation. Within a month, 6 had resigned rather than face disciplinary hearings. The remaining 6 fought back hard, hiring attorneys, filing counter-complaints, accusing Sarah of conducting a witch hunt against military physicians. Sarah didn't engage. She just kept presenting evidence. Surgical recordings, nursing complaints, patient outcomes, medical records that showed clear patterns of negligence. The evidence was overwhelming. 4 of the remaining 6 eventually accepted plea agreements, surrendering their medical licenses in exchange for avoiding criminal prosecution. The final 2 went to formal disciplinary hearings. Sarah testified at both. The first hearing was for Dr. Philip Ashworth. Sarah sat in a Pentagon conference room across from Ashworth and his legal team, surrounded by military brass and medical board members. The atmosphere was formal and hostile. Ashworth's attorney attacked immediately. "Ms. Brennan, you're a nurse with less than a year in an administrative position, correct?" "That's correct. And yet you're claiming to have the expertise to evaluate the surgical decisions of a physician with 17 years of experience?" Sarah met the attorney's eyes. "I'm not evaluating surgical decisions. I'm evaluating patterns of negligence." "That's a serious accusation. Can you define negligence for this board?" "Negligence is the failure to exercise reasonable care that a competent medical professional would provide in similar circumstances." In Dr. Ashworth's case, that failure is demonstrated by repeatedly dismissing clinical observations from nursing staff that subsequently proved to be accurate and could have prevented patient harm. The attorney's expression hardened. "You're basing this on the subjective complaints of nursing staff who may have had personal grievances against Dr. Ashworth." "I'm basing it on surgical recordings that show Dr. Ashworth dismissing specific clinical warnings, followed by patient complications that directly resulted from the issues those warnings identified." Sarah pulled out a transcript. Case number 4. A nurse reported abnormal bleeding patterns during a routine appendectomy. Dr. Ashworth dismissed the observation. The patient developed a postoperative hematoma requiring emergency reoperation. Case number 7. A surgical tech noted instrument contamination. Dr. Ashworth proceeded anyway. The patient developed a surgical site infection that resulted in sepsis. She continued through all 23 cases, her voice steady and precise, citing specific evidence for each one. Ashworth's attorney tried to interrupt several times, but Sarah didn't stop. She'd spent 3 months preparing for this moment, and she wasn't going to let procedural objections derail it. When she finished, the room was silent. Ashworth's attorney looked rattled. "Ms. Brennan, isn't it true that you have a personal vendetta against military surgeons based on your own negative experiences at Thornfield Hospital?" "No." "You don't harbor resentment toward Dr. Caldwell, and by extension, physicians he trained?" Sarah's voice was ice. "I harbor resentment toward negligence. Dr. Caldwell almost let a general die because he was too arrogant to listen. Dr. Ashworth has repeated that pattern for over a decade. My feelings about them personally are irrelevant. The evidence speaks for itself. The medical board deliberated for 4 hours. Their verdict was unanimous. Dr. Ashworth's medical license was permanently revoked. Sarah watched him leave the hearing room, his career destroyed, and felt nothing. No satisfaction, no vindication, just exhaustion. One down, one to go. Gauze. The second hearing was for a surgeon named Dr. Catherine Blake, a respected cardiothoracic specialist who'd been operating at military hospitals for 19 years. Blake's case was more complicated. Her surgical outcomes were generally good. Her mortality rates were within normal ranges. But the complaints against her showed a pattern of dismissing junior staff, creating a hostile work environment, and retaliating against anyone who questioned her authority. Sarah's evidence was less about patient deaths and more about systemic toxicity. Nurses who'd left military medicine entirely because of Blake's treatment, surgical residents who'd filed harassment complaints, staff members who'd been reassigned or demoted after speaking up. Blake's attorney argued that this wasn't medical negligence. It was personality conflicts that had no place in a formal disciplinary hearing. Sarah disagreed. Dr. Blake created an environment where staff were afraid to report clinical concerns, she testified. That environment directly contributed to multiple preventable complications. When nurses are terrified of speaking up, patients suffer. That's not a personality conflict. That's a systemic failure that Dr. Blake is responsible for. She presented documentation showing 3 cases where nurses had noticed potential complications but didn't report them immediately because they feared Blake's retaliation. All 3 patients suffered harm that could have been prevented with earlier intervention. The medical board deliberated for 6 hours. Their verdict? Dr. Blake was suspended for 2 years and required to complete leadership training and workplace conduct remediation before being eligible to practice again. It wasn't as severe as Ashworth's permanent revocation, but it was accountability. Real, public accountability for behavior that had gone unchecked for nearly 2 decades. Sarah left the hearing feeling like she could finally breathe. 6 months after taking the position, Sarah received a call from General Holloway. "I'm back on active duty," he said without preamble, "and I'm reorganizing my medical support team. I want you as my chief medical advisor." Sarah's heart jumped. "Sir, I'm in the middle of—" "I know what you're in the middle of. You've exposed negligence in 17 hospitals, suspended or revoked the licenses of 19 surgeons, and created a reporting system that's fundamentally changing how military medicine handles accountability. You've done more in 6 months than most people accomplish in their entire careers." Sarah didn't know what to say to that. "But you can't sustain this pace forever," Holloway continued. "I've watched you burn yourself out trying to fix every broken piece of the system. You need balance, a clinical role alongside the investigative work, a chance to do the medicine you actually love instead of just punishing the people who do it badly." Sarah's throat was tight. "What exactly are you offering?" "Chief medical advisor for my command. You'd oversee medical operations, coordinate with field hospitals, ensure my soldiers get the best possible care. And you'd maintain your oversight authority. If you see something wrong, you investigate it. But you'd also get to practice medicine again, save lives, do the work that made you who you are." Sarah closed her eyes. She'd spent 6 months fighting battles that needed to be fought, exposing corruption that needed to be exposed. But Holloway was right. She was exhausted, and she missed patient care, missed the direct connection of helping someone heal. "When do you need an answer?" she asked. "When you're ready to give one," Holloway said. "Take your time, think about it. But Sarah, you've proven you can tear down the people who deserve it. Don't forget that you're also supposed to build something better in their place." The call ended, and Sarah sat in her office staring at case files that would never stop coming. Holloway was offering her a way forward that wasn't just about destruction, a chance to use everything she'd learned to actually improve military medicine from the ground up. She made her decision that night. Sarah accepted Holloway's offer with one condition. She'd maintain her oversight authority, but transfer day-to-day case management to her investigative team. Morrison agreed immediately, recognizing that Sarah had built something sustainable that didn't depend on her personally driving every investigation. The transition took 3 months. Sarah trained her replacement, a former Navy nurse with 15 years of experience and the same stubborn refusal to accept negligence that had driven Sarah's own work. Together, they established protocols, refined the reporting system, created an infrastructure that could survive leadership changes. By the time Sarah officially transferred to Holloway's command, the patient safety office she'd created was handling an average of 200 new complaints per month, with a team of 12 investigators and a track record of successfully prosecuting negligence cases. It was working. The system was actually changing. Sarah's last day at the Pentagon, Morrison called her into the office one final time. "You did something remarkable," Morrison said. "You took a tragedy and turned it into systemic reform. That's rare." "I had help," Sarah said. "You had opposition. You fought through it anyway." Morrison handed her a folder. "This is the official after-action report on military medical reform efforts over the past year. I want you to read it when you have time. See what you accomplished." Sarah opened the folder that night in her apartment. The report was comprehensive, detailing every investigation, every policy change, every structural reform that had resulted from the work she'd started. The numbers were staggering. 19 surgeons suspended or removed. 43 hospitals implementing new protocols for staff reporting. Over 1,500 complaints investigated. An estimated 300 preventable complications avoided because nurses now felt empowered to speak up without fear of retaliation. But the part that hit Sarah hardest was the final section. A survey of military nursing staff conducted 6 months after the reporting system launched. 87% of respondents reported feeling more comfortable raising clinical concerns. 73% said they'd personally witnessed situations where speaking up had prevented patient harm. 92% said they believed the culture of military medicine was changing for the better. Sarah closed the folder and sat in silence for a long time. She'd spent 4 years in Syria saving 612 soldiers while losing 43. She'd spent 6 months at Thornfield being dismissed and humiliated. And she'd spent the last year fighting to make sure no other nurse had to experience what she'd experienced, and no other patient had to suffer what General Holloway had suffered. It still didn't feel like enough. It probably never would. But it was something. Sarah reported to General Holloway's command on a cold morning in March, exactly 1 year after the night she'd saved his life. Holloway met her personally at the headquarters building, looking stronger and healthier than he had any right to be after the trauma he'd survived. "Welcome to the team, Chief," he said, shaking her hand. The title felt strange. Sarah had spent her entire career being called Nurse or Brennan or nothing at all. Now she was Chief Medical Advisor, a position with real authority and real responsibility. Holloway showed her to her office, a small space with a desk, a computer, and a window overlooking the training grounds where soldiers were running drills. "Your job is simple," Holloway said. "Keep my soldiers alive. Keep my medical staff accountable. And if you see anything that reminds you of Caldwell or Ashworth or any of the other bastards you've taken down, you shut it down immediately. Understood?" "Yes, sir." "Good." Holloway headed for the door, then paused. "One more thing. I'm holding a briefing tomorrow with all senior medical staff. I want you there. Not as an observer, as my chief advisor, which means if anyone tries to dismiss you or talk over you or treat you like you don't belong, you shut them down. And if you can't shut them down, I will." Sarah felt something shift in her chest. "Thank you, sir." "Don't thank me, just do the job." Holloway's expression softened slightly. "You saved my life, Brennan. Now I'm giving you the platform to save a lot more. Don't waste it." He left, and Sarah stood alone in her new office, looking out at the soldiers below. She thought about Private Kerrigan bleeding out in her arms, about the 43 soldiers she'd lost, about General Holloway dying on the operating table while brilliant surgeons ignored her warnings. She thought about every nurse who'd ever been dismissed, every patient who'd ever suffered because someone in power refused to listen, every person who'd tried to speak up and been silenced. And she made a promise to all of them. This was going to be different. Not perfect. Nothing ever was. But different. Better. A place where clinical observations mattered more than hierarchy, where patient safety was prioritized over professional ego, where the people doing the actual work of keeping patients alive were respected and heard. Sarah pulled out her laptop and started reviewing the medical files for Holloway's command. 237 soldiers under care, 15 medical staff, 3 active deployments requiring field hospital support. It was a lot, but it was manageable. And for the first time in over a year, Sarah felt like she was exactly where she was supposed to be. The senior medical staff briefing the next morning was held in a conference room packed with physicians, nurses, and administrative personnel. Sarah walked in behind General Holloway and immediately felt the weight of every eye in the room. Some looks were curious, some were skeptical. A few were openly hostile. She recognized the hostility. She'd seen it at Thornfield, at the Pentagon, in every space where her authority challenged the traditional medical hierarchy. But she wasn't the ignored combat nurse anymore. Holloway opened the briefing by introducing Sarah and making her role crystal clear. Chief Brennan has full authority over all medical operations in this command, he said. If she identifies a problem, you fix it. If she raises a concern, you listen. If she tells you to stop doing something, you stop immediately. Are we clear? A few murmured acknowledgments, but most of the room stayed silent. Holloway's expression hardened. I asked if we're clear. This time, the response was louder. Yes, sir. Good. Because a year ago, I almost died because a surgeon was too arrogant to listen to a nurse's clinical observations. That's not happening in my command. Ever. Chief Brennan has my complete confidence and support, which means she has yours. Anyone who has a problem with that can request a transfer today. Nobody moved. Holloway gestured to Sarah. Chief, the floor is yours. Sarah stepped forward, her heart pounding but her voice steady. I'm not here to make your jobs harder, she said. I'm here to make sure we're doing them right. That means open communication. That means reporting concerns without fear of retaliation. That means putting patient safety above everything else, including ego, hierarchy, and professional pride. She paused, meeting the eyes of several senior physicians who were watching her with barely concealed skepticism. Some of you probably think I'm here to police surgeons or undermine medical authority. You're wrong. I'm here to support the staff who are trying to do good work and hold accountable the ones who aren't. If you're providing excellent patient care and listening to your team, we're going to get along fine. If you're operating like the surgeons I've spent the last year investigating, we're going to have problems. One of the physicians, a middle-aged trauma surgeon named Dr. Robert Hayes, raised his hand. Yes, Sarah said. With respect, Chief, you've built a reputation for going after military surgeons. How do we know this isn't just another witch hunt? Sarah had been expecting this question. She'd been asked variations of it dozens of times over the past year. Dr. Hayes, in the last 12 months, I've investigated over 1,500 complaints against military medical staff. Do you know how many resulted in formal disciplinary action? Hayes shook his head. 19, Sarah said, out of 1,500. That's just over 1%. The other 99% were either resolved through corrective action, found to be misunderstandings, or dismissed as lacking evidence. I'm not conducting a witch hunt. I'm conducting investigations based on evidence. If you're doing your job competently and treating your team with respect, you have nothing to worry about. Hayes looked somewhat mollified, but another physician spoke up. What about situations where there's legitimate disagreement about clinical judgment? Are we expected to defer to nursing observations even when we think they're wrong? No, Sarah said firmly. You're expected to listen to nursing observations and make an informed decision. If you disagree, explain why. Document your reasoning. Involve other team members if needed. What you're not allowed to do is dismiss observations out of hand because of rank or professional hierarchy. Clinical judgment isn't about who has the fanciest degree. It's about who has the most relevant information about the patient at that moment. She could see some heads nodding now. Not everyone, but enough. The briefing continued for another hour, with Sarah outlining reporting procedures, communication protocols, and expectations for the medical staff. By the end, the atmosphere in the room had shifted from hostile to cautiously cooperative. It wasn't perfect, but it was a start. 8. Over the next 6 months, Sarah built something she'd never thought possible, a medical command where nurses were actually listened to. It wasn't easy. She had to address multiple situations where senior physicians tried to revert to old hierarchical patterns. She had to mediate conflicts between staff members with different communication styles. She had to balance her investigative authority with her role as a collaborative team leader. But slowly, the culture changed. Nurses started speaking up during rounds without fear of being dismissed. Physicians started actively soliciting input from their teams before making critical decisions. Patient outcomes improved as more potential complications were caught early because someone felt comfortable raising a concern. Sarah maintained her connection to the Pentagon Oversight Office, reviewing high-priority cases and consulting on investigations. But her primary focus was on building the kind of medical environment she'd always wished existed. One afternoon, she received an email from Rita Vasquez, the ICU nurse from Thornfield. Sarah, I wanted you to know that things have changed here since you left. We have new protocols for staff reporting, new leadership in the trauma unit. Nurses are being heard. It's not perfect, but it's better. You did that? Thank you. Sarah read the email 3 times, her vision blurring with tears. She'd spent so long fighting battles that felt impossible to win. And now, finally, she could see the results. Real, tangible changes that were making life better for nurses and safer for patients. It still wasn't enough to erase the 43 soldiers she'd lost in Syria. It still didn't bring back the patients who'd died because negligent surgeons refused to listen. But it was something, and sometimes something was all you could ask for. 14 months after saving General Holloway's life, Sarah received an invitation to speak at the annual Military Medicine Conference in Washington. The conference was the biggest gathering of military medical professionals in the country. Thousands of physicians, nurses, administrators, and researchers presenting on the latest advances in combat medicine and military healthcare. Sarah had never spoken at anything remotely this high profile. The thought of standing in front of thousands of medical professionals and talking about her work made her want to throw up. But General Holloway insisted. "You have a story that needs to be told," he said. "Not just what happened in that operating room, but what you've built since then. The oversight system, the cultural changes, the lives saved because nurses finally have a voice. People need to hear that." Sarah reluctantly agreed. The conference was held in a massive hotel convention center. Sarah's presentation was scheduled for the final day, in the largest ballroom, right before the closing keynote address. When she walked into the ballroom, it was packed. Over 2,000 people filled the seats, with more standing in the back and along the walls. Sarah's hands were shaking as she stepped up to the podium. She'd prepared a presentation with slides showing data on the oversight system, case outcomes, cultural metrics. But standing there looking at the sea of faces, she realized that wasn't what these people needed to hear. They needed the truth. Sarah set aside her prepared remarks and spoke from the heart. 14 months ago, I was an invisible combat nurse at a military hospital in Detroit. I had 4 years of field experience and 6 months of being treated like I didn't know anything. Then a 3-star general came into our operating room dying from blast trauma, and I spent 4 hours watching him suffocate while the surgeons who were supposed to save him ignored every warning I gave them. The room was absolutely silent. I'm not here to talk about surgical technique or medical protocols. I'm here to talk about something more fundamental. The culture that almost killed General Holloway. The belief that expertise is determined by credentials instead of competence. The hierarchy that values a surgeon's authority more than a nurse's observations. The system that punishes people for speaking up and rewards people for staying silent. She paused, her voice steady but hard. I've spent the last year investigating negligence cases across the military medical system. Do you know what I've learned? The problem isn't individual bad surgeons. It's a culture that creates them and protects them. A culture that tells nurses their observations don't matter. That tells junior staff to stay quiet and follow orders. That prioritizes professional ego over patient safety. Sarah could see people shifting uncomfortably in their seats. Good. She wanted them uncomfortable. We talk about patient-centered care like it's a revolutionary concept. But here's the truth. Patient-centered care starts with listening to the people who spend the most time with patients. That's nurses. That's surgical techs. That's the staff members who are actually in the room watching vital signs change and bleeding patterns develop and airways compromise while physicians are focused on the big picture surgical problem. She pulled up a slide showing the statistics from the past year. Since implementing the oversight and reporting system, we've seen a 43% reduction in preventable surgical complications across military hospitals. That's not because surgeons suddenly got better at surgery. It's because nurses feel empowered to speak up, and physicians are finally listening. 467 complications prevented, an estimated 73 lives saved, all because we created a system where clinical observations matter more than hierarchy. The silence in the room had shifted. People were leaning forward now, paying attention. So, here's my challenge to everyone in this room, Sarah said. When you go back to your hospitals and your commands, ask yourself, am I creating an environment where my team feels safe speaking up? Am I listening to the people around me, or am I dismissing them because they don't have the right credentials? Am I prioritizing patient safety, or am I protecting my professional ego? She paused, her voice dropping. Because I can tell you from experience, if you're not listening, someone's going to die. And you're going to have to live with that for the rest of your career. Just like Dr. Preston Caldwell is living with the knowledge that he almost let a general die because he was too arrogant to listen to a combat nurse. Sarah closed her laptop and looked out at the audience. I didn't ask to become the face of this movement. I just wanted to do my job and keep patients alive. But if my story can help other nurses find the courage to speak up and help physicians find the humility to listen, then maybe all the fights I've had to fight were worth it. She stepped away from the podium. The applause started slowly, a few people clapping, then more, then the entire ballroom rising to their feet. It wasn't polite conference applause. It was real, sustained, emotional applause from people who'd lived through similar experiences and finally felt validated. Sarah stood on the stage with tears streaming down her face, overwhelmed by the response. After the presentation, she was surrounded by nurses thanking her, physicians asking how to implement similar systems at their hospitals, administrators requesting consultations on cultural reform. But the person who pushed through the crowd to reach her was someone Sarah hadn't seen in over a year. Dr. Marcus Webb, the trauma surgeon from Thornfield who'd let her talk him through a vascular repair. I came to say thank you, Webb said. You changed how I practice medicine. I listen to my team now. I ask for their input, and I'm a better surgeon because of it. Sarah's throat was tight. You were always a good surgeon, Dr. Webb. You just needed permission to trust the people around you. No, Webb said firmly. I needed someone to show me what it looks like to actually put patients first. You did that. He walked away, and Sarah stood in the convention center hallway, feeling like maybe, just maybe, the fight had been worth it. Okay, 2 years after saving General Holloway's life, Sarah received a letter from the Department of Defense. She opened it in her office at Holloway's command, expecting another administrative notification or policy update. Instead, it was a commendation. For exceptional service in the advancement of patient safety protocols and medical oversight systems, resulting in measurable improvements to military healthcare quality and the prevention of an estimated 847 adverse patient outcomes. Sarah read the letter 3 times, her hands shaking. 847 adverse outcomes prevented. That was 847 patients who didn't suffer preventable complications. 847 families who didn't lose someone because a surgeon refused to listen. 847 lives that had been saved by the system she'd built. It still didn't bring back Private Kerrigan. It still didn't erase the 43 soldiers she'd lost in Syria. But it meant something. That evening, Sarah drove to Arlington National Cemetery. She hadn't been there since transferring back to military service, but she needed to do this. She found Kerrigan's grave in Section 60, marked with a simple white headstone bearing his name, rank, and dates of service. Sarah sat on the cold ground beside the grave and spoke to a kid who'd been dead for 3 years. I'm sorry I couldn't save you, she said quietly. I tried everything. It wasn't enough, and I've been carrying that for a long time. The cemetery was silent except for the wind moving through the trees. But I think I finally understand something, Sarah continued. You didn't die because I failed. You died because war is brutal and injuries are catastrophic, and sometimes there's nothing anyone can do. What I did after, building the oversight system, holding surgeons accountable, giving nurses a voice, that was how I made your death mean something. Because every patient we save now, every complication we prevent, that's your legacy too. She stood up slowly, her eyes burning with tears. So thank you, Kerrigan, for teaching me that sometimes the best way to honor the people you couldn't save is to fight like hell for the ones you still can. Sarah walked back to her car and drove to Thornfield Military Hospital. She hadn't been back since leaving for the Pentagon 2 years earlier. The building looked the same, imposing, institutional, unchanged. But Sarah knew everything inside had changed. She walked through the main entrance and headed straight to the ICU, where she'd spent 14 days keeping General Holloway alive. Rita Vasquez was at the nurses' station. When she saw Sarah, her face lit up. Look who finally came home, Rita said, hugging her tight. Just visiting, Sarah said. How are things? Better, so much better. Rita gestured around the ICU. New protocols, new leadership, nurses on the trauma advisory board. We actually have a voice now. You did that. Sarah shook her head. We did that. I just started the fight. You kept it going. They talked for an hour, catching up on hospital politics and case outcomes and the slow, grinding work of cultural change. Then Rita walked Sarah down to the operating room wing. I want to show you something, Rita said. She led Sarah to operating room 3, the room where Holloway had almost died, the room where Sarah had defied orders and brought him back. The room looked different now. There was a plaque on the wall, small, unobtrusive, but permanent. Sarah read the inscription. In honor of Sarah Brennan, combat nurse who taught us that courage means speaking up even when nobody's listening, and that true medical excellence comes from respecting every voice on the team. Sarah's vision blurred with tears. The staff voted on it, Rita said quietly. Every nurse, every tech, every resident who was tired of being dismissed. We wanted to make sure nobody forgets what happened here, what you did. Sarah couldn't speak. She just stood there staring at the plaque, remembering that night. The fear, the desperation, the absolute certainty that she was right even when everyone else said she was wrong. Thank you, she finally managed. No, Rita said firmly. Thank you for being brave enough to fight when the rest of us were too scared. Sarah left Thornfield that evening feeling something she hadn't felt in years. Peace. Not the absence of pain or trauma or difficult memories, but the knowledge that she'd taken the worst moments of her life and turned them into something that mattered. That Private Kerrigan's death had taught her to fight for the living. That General Holloway's near death had given her the platform to change the system. That every ignored warning and dismissed observation had become fuel for building something better. She drove back to her apartment and sat down at her laptop. There were 37 new cases in the oversight system queue. Complaints from nurses who felt comfortable speaking up now because Sarah had shown them it was possible. Reports of potential negligence that would be investigated fairly because she'd built a system that actually worked. Sarah opened the first case file and started reading. There was still work to do. There would always be work to do. But for the first time since Syria, Sarah Brennan wasn't running from the people she'd lost. She was fighting for the ones she could still save. And that made all the difference.